I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the true privilege that is mine. Take from my God all guile and worldliness, that with the simple faith of a child I rely on thee.
Thank you, sir.
Thanks.
I am Dr. Nirmal Frederick, Chairman of the AMS wing of IMA Tamil Nadu. I'm glad to welcome you all to this Amscon 2026. Respected Dr. Sridhar, State President, immediate past President Dr. Sengutuvan, Secretary Dr. Theraviam, and our esteemed state office bearers, past presidents, and our national leaders, Dr. Venkatachalapati, National Chairman, Dr. Chairman, Dr. Sairam, National Secretary, and all the distinguished faculty here, and my colleagues, Dr. Sendil Kumar, working very hard for this conference, and Dr. Mohammad Ibrahim, Joint Secretary, all the President Secretary of various IMA branches, and dear delegates joining us from across Tamil Nadu and beyond. A very good evening and warm welcome to Tamil Nadu AMSCon 2026, the annual conference of the Academy of Medical Specialties Wing IMA Tamil Nadu. Sir Dr. Sridhar, President IMA, it's a privilege to have you open this conference under your leadership. Your consistent encouragement of academic activity has given the AMS wing both direction and confidence, and we are honored to have you inaugurate this conference today. So what lies ahead of us? 5 days, 5 specialties. The Tamil Nadu AMSCon 2026 has been designed as a 5-day academic feast held online so that no doctor in Tamil Nadu is left out by distance. So today, 14th July, we'll be covering on vaccination and infectious diseases. And tomorrow we'll be covering ophthalmology, and 16th July, ophthalmology, 17th July, fetal medicine and breast cancer. And on the last day, 18th July, we'll be having plastic surgery in live and hybrid mode. So 3 hours each evening from 3 to 6 p.m. and 5 medical council credit hours for those who attend all 5 days. So this is the very idea of the AMS wing in action, that a doctor of one specialty must know enough of others to protect the patient in front of them to provide quality and safe medical care. All our faculty and speakers joining us today, 5 days. You are the reason this conference exists and set a benchmark that over 3,500 doctors have registered for this. Kudos to our AMS team, especially Dr. Sendil and Dr. Ibrahim, and all those who supported him from Polachi IMA and all the supporters. To our supporters and the IMA State Office, thank you for the hard work and making this 5 days across 5 specialties look effortless. And to all our delegates, thank you for choosing to spend your evening tonight with us. So come with your questions, use the chat box, stay for the discussion, log in on all 5 days, and you will walk away with a broader clinician than you were last week. So with these words, I'll welcome all of you for this Tamil Nadu AMSCon 2026. Happy academic feast to all of you.
Thank you, sir. Yes, sir. So now I request our State President, Dr. Sridhar sir, to inaugurate the conference.
Good afternoon, everybody. Already I've crossed 1K. A very good beginning for the sessions ahead. Most respected President-elects, Dr. Ravi Kumar and Dr. N.R.T. Nagarajan, my own secretary, Dr. Theraviam Mohan, Treasurer Solomon, they are the doyens of AMS. I should call them the doyens of AMS, Dr. Nirmal Frederick and Dr. Sendil Kumar, and their chairman and secretary at the national level, Dr. Venkatachalapati and Dr. Sairam sir. My immediate past president and the lovable brother, Sengutu Anna, all the other leaders, I may have missed out because I may not have noticed their presence. All the office bearers of IMA online, the delegates who have shown so much of immense interest I'm told by Dr. Sandil, it has already, the registrations have already crossed the 3,000. He was asking me permission to expand it beyond 3,000. I said, no, let it come at a premium. If at all, people let them you register well in advance so that we know how much of numbers. Maybe next time we may expand it. So the 3,000 range has been arrived at. Congratulations, team AMS, especially Dr. Nirmal. I want to tell you something. Morning, afternoon, evening, like TAD dosage of a medication, Dr. Sandil Kumar will call me. My wife will
Yes,
smile
sir.
a little bit whenever she sees the name cutting across the viewing. Ah, உங்க ரெண்டாவது முன்னாடி வந்தாச்சு லைன்ல. On that to that extent, he was
Yes,
talking
sir.
to me every day in and out, meticulously getting clarifications, cross-checking the brochures, the programs, how the protocols, how it is to be done, and all everything. Uh, Yet event is not held successful just over a day. You may see it as a function of a particular day, but the law preparations you make to make it a successful day, it takes a lot of days. And I am very sure தெய்வத்தால் ஆகாதெனினும் முயற்சித்தன் மெய்வருத்த கூடித்தரம், if that Quran is right, this conference is bound to succeed enormously in a big scale simply because of the efforts the AMS team has put in at Tamil Nadu, especially Sandil Kumar, Nirmal. I will give him the first credit, I give you only the second credit. To what extent he has done his efforts, taken efforts in making this event very successful. I am told that the 5 chapters, infection, pulmonology, ophthalmology, my own field, Nirmal, you forgot me. I would have at least given the parts of an eye as a beginning. Then we have this fetal medicine and breast cancer, and then plastic surgery, which will be a oration lecture there mainly, and Rajya Sabha will be oration, and all the faculties have been handpicked. I will say all the faculties, and they are the doyens in their own field, in their own way, with the latest of technology in the fingertips. And I'm sure every delegate who attends this conference immensely will benefit. It will be a pleasure being there on the end of the day, on the last day of the function, for the penultimate function. In Pondachi in person. I wish this event a great success. And Muhammad Ibrahim, I forgot to mention you. My many apologies to you. You have been you have gelled as a wonderful team. And once upon a time, when I was young, AMS post was offered as a staff. ஏதாவது ஒன்று கையில் வச்சுக்கோன்னு சொல்லி ஒரு போஸ்ட் மாதிரி கொடுப்பாங்க. Those days, it was a consolation prize for people vying for a post. But today, AMS is coming at a premium now because of its performance, because of its reach, because of the excellent hard work put in by the office bearers, previous team, current team. And I'm very happy about that as your president. It is a great pleasure to be your president when such good events are taking place. Thank you, Sandil. Over to you.
Thank you, sir. Thank you so much for your kind words, sir. Now I request our state secretary, Dr. Dirivi Mohan, sir, to give us some.
Sir, Senguton sir பேசிட்டு sir.
Okay, sir.
Senguton sir.
Sir, now I request our immediate past president, Dr. Sengutun, sir, to give his felicitations.
Thank you, Dr. Sindhil. Respected State President, Dr. Sridhar, Honorary Secretary, Dr. Dravi Mohan, Finance Secretary, Dr. Solomon Jaya, Academic Wing, headed by Dr. Nirmal Frederick, Dr. Sendil Kumar, Dr. Ibrahim, and National Swards, Dr. Venkatalapati, Dr. Saira, and speakers of the day, Dr. Neminathan. And every day we are having different subjects. Today, vaccination, tomorrow, pulmonology, day after tomorrow, ophthalmology, infectious disease, and lastly, plastic surgeon, as usual by Ganga Hospital. It is really very glad to see that Dr. Sendil Kumar and Frederick, they are doing wonderful job for this academic event, and this academic event is giving 5 points, 5 grade marks to the academic session. Easily, who are the people who are having the conference 30 marks for the 5 years? Easily, they can avail every year. They can participate in this meeting. If we recommend that only if IMA people is joining, those who want 5 marks, they can 5 points. They can easily we can compel the non-IMA people to be the member of the IMA, so that we can easily increase the membership of the IMA, so that everything will go smoothly. So I wish the team a great success and do wonderful job as usual. Thank you. Over to Dr. Sendil.
Thank you, sir. Sir, in fact, there are a lot of people becoming IMA members gradually, sir, from all our AMS and CGP CMEs. Thank you, sir.
Thank you.
Yes, sir. So now I request our President-elect, Dr. Ravi Kumar, sir. I think sir is yet to join, sir. Dr. NRT, sir, to give his felicitations.
Good afternoon. Thanks, Dr. Sendil. Amazing work as usual by the AMS. And this conference, almost every year we are, last time I think with the CGP also, we had more than 3,500 registrations. Amazing work, and looking forward to the valedictory on the 18th. And congrats again to the entire team for this teamwork, because 3,500 registrations, I really don't know how you actually reach those numbers, but congrats once again to the team, and lovely daily topics also, and looking forward to meet you all on 18th. Thanks, Dr. Sendil, for this.
Yeah. Thank you, sir. Thank you, sir. Now I request our State Secretary, Dr. Dirav Mohan, sir, to give his address. Sir, Dirav, sir.
வேற வழி இல்லை, ஏதாவது ஆல்டர்னேட்டே வந்துகிட்டே இருக்கும்.
Just a minute, sir.
Sir, good afternoon and warm greetings to everyone. On behalf of the IMA Tamil Nadu State Band Team 2026, I warmly welcome all the delegates, faculty members, and participants joining through Zoom. A special welcome to our national and state office bearers, chairpersons, speakers, and moderators. And I should especially thank Chairman Nirmal Frederick Sir, Sendil Kumar, and Mohammad Ibrahim for the excellent steps they have taken to make this Tamil Nadu Amscon a great success. Because 5 days they're covering at 5 topics. And today our infectious topic, vaccination infectious disease. I'm happy our national president-elect, Dr. Singarvelu sir, is chairing the session. I request all the participants to keep the microphones muted, actively participate in the discussions, and post questions through the chat and or question and action section, because very important, because we have to be very, because we have a CME online. We can have credit points, 5 credit points, even at home, we're able to get those 5 credit points. And I invite everyone to make the best use of the academic opportunity and participate in all the 5 days conference, and wishing the conference a success, and wishing the team a success. And we'll meet on the 18th at Pollachi for the valedictory function, sir. Thank you, sir. Thank you, sir.
Thank you, sir. Sir, now, yes, sir. Now, Dr. Singarwal sir has joined now, sir. Yes, sir. Sir, now can we proceed with our session, sir?
Yeah, proceed, sir. Proceed.
Yes, sir. Yes. Now I request Professor Singarwal sir, National President-elect IAP 2026.
Yes, sir.
I welcome sir to be a moderator for this wonderful session, along with Dr. C. Satish sir, Senior Consultant Pediatrician, Apollo, Chennai. So, Dr. Singarwal sir, he has received Marathuva Natchatram.
Before Dr. Singarwal sir starts the whole thing, I'm very happy to welcome Dr. Singarwelu, the National President of IAP, to this conference, that too as a moderator. I am very, very proud to have him as my alma mater. And welcome, sir, Singarwal sir, along with your colleague, Dr.
Sir, President. Thank you all.
Sir.
Yes, sir. Yes, sir. Most welcome.
Yes, sir. So, Sir has received Maruttva Natchatram Award by Hindu and IMA Tamil Nadu, Dr. Jayaraj Ayyan Nadar Oration Award by IAP Tamil Nadu, Mamannan Rajarajan Award by Tamil Nadu Government Tanjavur, Best Teacher Award, and various other awards and accolades. And Dr. Satish is also our moderator today. He is a senior consultant from Apollo Children's Hospital. He is a chairperson, Tamil Nadu GDPP subchapter, past president IAP Chennai City branch, organizing chairperson, Pedicon 2019, examiner Pediatrics National Board of Examination. I welcome you both for today's session and request you to proceed with the academic sessions in a wonderful way. Thank you, sir.
Sendil sir, I would also
Thank
like
you
to,
so much, sir.
Sendil sir, I would like to interpret.
Yes,
Dr.
sir.
Singaravel is receiving the national award from IMA this year, sir. Congratulations, sir.
Okay.
Thank you.
Yes, sir.
Thank you.
Super, sir. Congrats, sir. Yes, sir.
Thank you. Thank you, Dr. Sendil, sir, our AMS wing person, and Frederick and Ibrahim. With our state leaders, Dr. Sridhar, my good friend, and our Sengutuan sir, Ravi Kumar, Tyarajan, and Dravya Mohan, and all the leaders of various branches. I'm very, at this juncture, first of all, my sincere thanks for electing me, because all IMA members, many of pediatricians are here. They gave the opportunity to run our prestigious organization of IAP from Tamil Nadu after 30 years, sir. Second, I sincerely thank Sendil and the team for giving me the opportunity to moderate, along with my good friend Dr. Satish, also here from Apollo. And today, the topic is very, very important as we are going to reach our monsoon soon, about our infectious disease and as well as vaccination. As you all know that vaccination is a very cost-effective tool to control major vaccine preventable disease. And we, Tamil Nadu, stand ahead of India, all because of advancement, our commitment by both pediatrician and all the doctors working with the government and in private practice. And I am happy that our IMA Tamil Nadu is doing extremely good work, that AMS wing, my good friend Venkatachalapati being chair, my EB member in IAP is chairing this national AMS wing. It is a really proud moment that within a short time, 1,000 members I never heard of, because I have been in a national IAP, very difficult to catch even 200 people and all that. And within a short time, 1,000 and others have joined in YouTube. It's a very proud moment. So hats off to our members of Tamil Nadu for knowing and the interest on getting a knowledge about this. So for this, I should do justice as a moderator. I don't want to waste much time, but today's topic is all very important. About one is pediatric vaccination, adult vaccination, and tropical infection disease, and also lab investigation. So as we have got a lot of, one thing is what we are following UIP, and second, IAP has got our own schedule. Surely you, a lot of IMA members should aware of what are the recent vaccinations which was not available in the government, because we are insisting. I was fortunate, 2 days back, I met our national vice president of the government, Honorable C.P. Radhakrishnan, and my first point in my agenda was to bring a lot of vaccines which are available to the UIP schedule. He immediately asked the Health Secretary Department, immediately he said he forwarded my memorandum, where first thing is MMR to be included, which is cost effective and other things. So this has happened just 2 days back. Soon the government is considering our request. So with this, today, first speaker going to be Dr. Shyamala, senior consultant, our own colleague, who is going to talk about pediatric vaccination, followed by Dr. Satish, who will talk about adult vaccination, and my good friend Nemi is here, who is going to talk about pediatric infectious disease with Raghunandan and others. So without wasting much time, and please
I request all
அட்டன்
members
பண்ணிட்டு தான் இருக்கேன்.
to
காதுல
get
கேட்டுட்டேன்.
muted.
சவுண்ட் ரொம்ப
And
கம்மியா இருக்கு.
sir, Senthil sir, you should have a one
அவ்வளவுதான் மேக்ஸிமம்.
person. Even now,
Yes, sir.
somebody is. So who should immediately mute whenever somebody is.
Yes, sir.
opening. Otherwise,
Okay,
the
sir.
flow will.
Yes, sir.
get,
Juliet கொஞ்சம் கரெக்டா மியூட் பண்ணிடுங்க. பாத்துட்டு இருங்க கரெக்டா.
that please ask.
Yes, sir.
Thank you so
Sir,
much, sir.
please. Yes, sir.
This is Dr. Satish,
Satish,
Apollo Children's Hospital.
Go to Satish sir. You carry on, Satish sir. Unmute and speak.
Yeah, Amscon has been a wonderful endeavor, and where I join the tone of Dr. Singarvelu sir, my elder brother, who has told us that it's such a to be getting an opportunity among the galaxy of speakers, along with my elder brother Singarvelu sir and all others, and that it's a day memorable in my life. I thank you for the opportunity given. I'll also join and do my best for the best success of the conference. Thank you.
Thank you, Satish sir.
I request Dr. Shamla to take over.
No need for introduction of Dr. Shamla, very active IAPN pediatrician, and she's a senior consultant in Apollo. She's doing a wonderful work in ID, and she is going to talk about first topic. Madam Shamla, over to you, ma'am. You can share it. And once again, I thank my good friend Nemi, who was instrumental in getting me for this program. Thank you.
Thank you, sir. Thank you so much.
Over to Shamla, ma'am.
Thank you, Dr. Singarvelu, Amscon organizers, and Tamil Nadu IMA branch for this opportunity. I think a lot of effort has gone into organizing this conference, and frankly, I too have not seen so many participants online. I hope I'm audible. Am I audible?
Very well, madam. Very well audible, madam.
Okay.
You can
I'll just share my slides. Can you see my slides?
No, madam. No, madam.
No?
No.
1 minute, okay.
Are you made as a co-host?
Just give me a minute.
Made as co-host, madam?
Share, 1 minute. I'll share this. Can you see my slides now?
No, madam. Sir, Senthil sir, have you made madam as co-host, sir?
Yes, sir. Yes, sir. Shamla ma'am is a co-host on this.
Now it's now, okay.
Yeah.
Okay.
Now visible, madam.
Is my slide visible?
Yes, madam. Perfect. Perfect.
Oh.
All the best. You can proceed, madam.
Okay. Can I proceed?
Yes, ma'am.
Hello.
You can proceed, madam.
You can proceed, ma'am.
Okay. Okay, thank you. Vaccination is a huge topic, so now I've been asked to condense it into 20 minutes. I hope I can do justice to this. These will be the headings under which I will be speaking. Initially, the science behind vaccination, the schedules, some practical rules, some common vaccines we use, a little bit about efficacy and failure, and lastly about cold chain. So what is vaccination? Is the process of distributing and administering vaccines at the correct scheduled time. And this is a cornerstone of protecting children from various vaccine preventable diseases. So India's vaccination journey started in 1974 when we started the expanded program of immunization, and it was christened UIP, Universal Immunization Program, in 1985 by the government. Universal, no child is denied protection against common infectious diseases. So a little bit about what happens when there is an actual infection. The first line of defense is mounted, which is the innate immune system. So the scavenger cells destroy germs and activate the adaptive immune system. The adaptive immune system, the two arms are humoral immunity and cell-mediated immunity. B cells generate antibodies, and T cells detect and kill virus-infected cells. So the B cells and T cells continue to patrol the body so that when the body encounters this infection next, we are ready with our defense. Now, vaccination kind of mimics this so that it actually introduces the body to a weakened version of the actual organism so that the body is primed to fight against disease without actually encountering the disease. So there are 4 fundamental vaccine types depending on what is the antigen that's used to prime the body. One is a live attenuated vaccine where the pathogen is weakened but enables the body to elicit a strong immune response. The next is the killed or inactivated vaccine, where the whole pathogen is inactivated using heat or chemical treatment. Here, the pathogen cannot replicate. Next is the subunit vaccine, where only certain parts of the organism are used which best trigger immunity. These are called epitopes. The fourth is toxoid. So these are inactivated bacterial toxin where the body is trained to recognize and neutralize the natural toxin. So this many lives have been saved by use of vaccines. So we can see that it's a huge number. So we should try as much as possible to counsel our patients for active vaccinations. Even in this day and age, we still have some families that deny vaccines for various reasons. So going to discussion of the live attenuated vaccines, some of the examples are BCG, OPV, MMR, varicella, and rotavirus. So these contain modified strains of bacterium or virus that are able to multiply within the body. They are remaining antigenic, but still do not evoke disease. So this produces a durable and often lifelong immunity. So the killed and inactivated vaccines, examples are inactivated poliovirus vaccine, whole cell pertussis, rabies vaccine, and hepatitis A vaccine. So these cannot multiply in the body, so a single dose is not sufficient. You may have to give multiple doses of these vaccines to sustain immunity. So it requires repeated dosing, as I said. The third is the subunit vaccines. So where only a part of the microbe is used, which evokes an immune response. For example, hepatitis B vaccine. Again, you will need multiple doses of such vaccines. Toxoid vaccines are example is diphtheria and tetanus. So just a summary of the different types of vaccines and the examples. So live attenuated
Madam, please unmute yourself. Madam, Dr. Shamla, madam, please unmute yourself. You are not audible.
Sir, actually, madam is unmuted only, but I think she's not audible.
And her screen also has gone.
Yes, I'll call her, sir. I'll call her over phone.
You call sir.
Yes, sir. Yes, sir.
So till madam joins, she is giving about the vaccines, how the different types of vaccines, and she was telling about what are the live and killed vaccines which are available and at this point of time. So we know that you are having a universal immunization schedule program, which I already told, and IAP has got other things. Because we have eradicated polio, we have eradicated smallpox, now DPT, I mean diphtheria, pertussis, tetanus, everything is under control because of the better vaccination efficacy. Though the government is doing its best, in UIP, it has brought the rotavirus because of our efforts in even pneumococcal vaccine, which is one of the costliest, where we were getting a lot of rheumatic or streptococcal infection. All have been under control. Haemophilus influenza, which has also reduce. So, but we have to include certain vaccines which government is not able to do it. For example, varicella vaccine, typhoid vaccine. So typhoid incidence has reduced. Previously, we were giving vaccine up to after 2 years only. Now, typhoid vaccine is available, which can be given at 6th month itself. Like flu is one of the very common problem which we are facing. Lot of deaths were occurring. Now, influenza vaccine has come. So influenza vaccine can be given at 6th month. So you can give typhoid vaccine and influenza vaccine. 2 doses can be given, which is having better control over it. Then coming to that, by 9 months, we are instead of government was giving MR vaccine. Initially, they were giving only measles. Now, rubella is included. That is why we are taking now incidence of mumps also increasing, and it is a silent, hidden at the point of time. It will not produce much effect. Later on, infertility is one of the major issues. People who are suffering from mumps disease. So that MMR vaccine is there. So in around 1 year, we are giving vaccines of varicella. We are giving vaccines of hepatitis A virus. So hepatitis A, one of the major disease which produces acute viral hepatitis, being very much reduced by introducing that hepatitis A vaccines. So, and MMR vaccine, 15 months, we give a second booster. Then 1.5 years, the same schedule what our government follows, DPT and all that. So by 2 years, we give other vaccines. So, and like that, we are continuing hepatitis A. 2 doses should be given. It should be given at 12 months and 18 months. So 2 doses should be given. At 15 months, we should give another dose of varicella. Initially, the concept is constantly changing. Initially, single dose of varicella was giving lifelong immunity. Now we have to give 2 doses, one at 12 months and we have to give at 15 months. Hepatitis A, 2 doses at 12 months, and after 6 months, 18 months, we have to give a dose. So these are all the vaccines which are not available in the government. As a practitioner, you should be aware that what these vaccines, how it has to be given. Because you will be having all your pediatric colleagues, but your own kids and kins, your own grandpa, seniors, grandchildren, for youngsters, their own kids, they do follow their vaccine. But what one advice I want to give before madam comes, see whatever vaccines now many even general practitioners also giving. One precaution you have to do that. So if you get adverse events following vaccination, if at all you get, you should be able to handle that situation. So my sincere advice as a person where you have to have the common things like whenever you give, whatever it is, not only for vaccination, any injection you are giving, you should be able to have adrenaline, 1 ampule. After all, it should be ready. And ambu bag, it is freely available. It was not no more. It is not a luxury. So you must have some basic ambu bag, oxygen. So these are all the basic things which are needed. Whatever it is, not only for vaccines, we are giving any injection. Many times now we are facing a lot of litigations. So if some anaphylaxis comes, something goes wrong, we have to be aware of this. So these are the thing when you are talking about vaccines. One is schedule, which we very clearly give IAP, UIP, everybody is giving, I have given the overall vaccines. Now the recent development is dengue vaccine is on the way. So now we are getting lot of cases of it is on trial, it will come. RSV vaccine is on trial. Malaria vaccine is on trial. Cholera vaccine already have come. So these are all the newer vaccines which are in the pipeline, which are going to come soon. So you all should be aware that. And as I told you, the adverse events following vaccination is a very important thing, where any clinic you are running in a OPD, you should have a basic thing, drugs like that, adrenaline, steroids, and you have to have oxygen, ambu bag. You should sensitize our people. Second thing, moment you give any vaccine, you should not ask a patient to leave. You have to keep minimum half an hour because anaphylaxis can occur. It is not one injection pain shock. Second thing, it may produce reaction for anything. But I cannot say this particular vaccine and all that. Any vaccine, any injection can produce. So we should be aware to anticipate certain problems even in our normal day-to-day life. So these are the aspects where when you talk about vaccines, one is what are the vaccines which we are giving? Second thing, what route? See, is there are different vaccines. Say, for example, if a live vaccine, killed vaccine, if the killed vaccine, say, for example, DPT, diphtheria, pertussis, now we have pentavaccine, that is 5 components are there, 6 components called hexavalent, where we have diphtheria, pertussis, tetanus, injectable polio, hepatitis B, Haemophilus influenza, all 6 things. So these should be given deep intramuscular. Suppose you give the route by subcutaneous and other things, it will not work. So you should know what vaccine, which route it should be given, and what are the other problems which you can anticipate. Like that rotavirus vaccine, it should be given orally. And nowadays, oral polio, we are giving only at the time of birth. So we are not routinely, we have gone from, because to prevent vaccine-derived viruses, which can become a wild polio virus, because we have not eradicated polio. We have only eliminated from our country. It is present in our neighboring countries, Pakistan and other places, Nigeria, it is there. Though the incidence has come down, at any point of time, as we got in COVID, these diseases can occur anytime. So we have to prevent those diseases by continuing our vaccination. So in this way, I think immunization is a very important aspect in pediatric, which will be continued by Dr. Suresh Kumar for during adult vaccination. Since Madam is not there, Nemi, I think I give overview. Any question and answer we can take for 5 minutes, then we can go to the next topic, I think. Satish,
Yes, Satish, if there are any
Satish,
questions in the chat box, you can ask. Thank you, Dr. Singaraveli, sir.
Yeah, somebody, I will answer for HPV vaccine. Yes, sir. Yabin Sam has asked, Nemi, in the meantime, just you go through what are the questions asked. I will answer for HPV. HPV is a very, very safe vaccine, sir. It is similar to any other injection only. It should be given from 9 months to 9 years to 14 years. 2 doses at a 6 months interval. It is now government has introduced a single dose, though the studies have said that definitely it is protective. So actually we recommend 2 doses if we given it is below 14 years, up to 15 years. Beyond 15 years, we advise 3 doses, or any immunocompromised people will we give 3 doses. Otherwise, now government has introduced for a single dose at the age of 14 years. Ideally, for our own children, it should be started from 9 years onwards. We can give up to 14 years, 2 doses, 6 months apart. It is a very, very safe vaccine. Maybe any other questions, if you could see in that.
Which is currently included in Tamil Nadu government program, sir? Which vaccine?
Hello. Well, the latest they brought pneumococcal vaccine, which was not there previously. This pneumococcal vaccine they have not given for all, only very extreme preterm children and those who are prone to get diseases. They have included in our vaccine schedule. Apart from the that of all other vaccines are already there. HPV vaccine is introduced by the central government. It is a part of it. We are also giving that. Soon it will come to all other thing also. I think with this, if there are no more questions, we can go for adult vaccine. Dr. Suresh Kumar sir, and he is a very infectious disease person. And adult vaccines are nowadays very important. Why? Because to prevent diseases to children also by immunizing adult, because many diseases are contracted by children from adult only. So now we thought that once we immunize children, adults are okay. Few diseases after a few years, their immunity has come down, like diphtheria, pertussis, all the immunity has come down, which we thought that it will have a lifelong immunity. So that now we are not seeing certain diseases which we are having in children. Now they are shifted to adult. So adult vaccination plays now a very vital role. What we were talking about adolescent as well as adult vaccines. And surely Dr. Suresh Kumar, who is a senior consultant of ID Apollo Hospital, he is going will talk to. If there are no more queries, I request Suresh Kumar to take over for his proceedings, sir.
Sir, there's a question about ARV, anti-rabies vaccine. How long does the ARV vaccine give protection?
Yes, this is multiple. So what we say whenever we come across, now we immediately how many doses they gave. So for example, in a post-exposure prophylaxis, pre-exposure prophylaxis, there are two things. And in our country, pre-exposure prophylaxis is not being very much into that. We are always going for post-exposure prophylaxis. What we recommend nowadays is pre-exposure prophylaxis. It means those who are prone, especially those who are having pet dogs in the family and those who are likely to be affected, we advise 3 doses, 0, 7, 40 days we advise. If it is so, it will have a protection of 6 months up to 1 year, we say, and it has to be given. In a post-exposure prophylaxis, what ideally people say, even you are giving today, hardly it may be 3 months to 6 months. But within 3 months, if the child had another bite, or depending on the type of, is it is a type 1, type 2, type 3. If it is type 3 and all that, we have to give again, continue the post-exposure prophylaxis properly, because it is a one virus. Nobody can say how it can behave when the person manifests disease. Once the patient develops the disease, 100% mortality. I can say one disease which has got 100% mortality is only rabies. So it will not occur if 6 months, 1 year, even 5 years, 10 years later also patient who had had a dog bite, ignored totally. They did not have post-exposure prophylaxis properly. So they had developed rabies. So post-exposure prophylaxis, 5 doses or monoclonal antibodies, whatever it is given, it has to be in 6 months. If they have another bite, it has to be followed in another post-exposure prophylaxis.
Thank you very much, sir.
Okay.
I like to, as Tamil Nadu coordinator of infectious disease certificate course of IMA, I like to add some more points along with Dr. Singarwali, sir. Thank you for elaborately answering about ARV. Please, friends, please remember, whenever there is an exposure to any warm-blooded animal, like dogs or cats or any other domestic animal that is warm-blooded, or all animals in the forest, wild animals, you need to give post-exposure prophylaxis. Among the exposure, there is a category 1, which is minor petting or just feeding the animal. That is category 1, for which no vaccination is required. Category 2 is a minor bite without bleed in non-danger areas. So that's category 2. There is no bleed, there is only minor bite. There is a small scratch or pawing. Not only biting, it's pawing also is equivalent to biting. That is category 2, in which, as Dr. Singarwala sir has told, you have to give 0, 3, 7, 14 and 28, 5 doses. That's very, very mandatory. On category 3, whenever there is a multiple bites or whenever there is a bleeding from the bite site, or in danger areas like face or genitalia or palms and soles, where the nerve endings are more, the entry into the axon is risk is very high, you need to give, along with monoclonal antibodies or rabies immunoglobulin, you have to give the 5 doses. Nowadays, we do use rabies monoclonal antibodies called Rabies Shield in the dose of 3.3 IU per kg. That has to be given on the day 0 itself, along with day 0 vaccine. And if there is a re-exposure later, within 3 months, if they get re-exposed, no need for vaccination. After 3 months, if there is a re-exposure, you need to give 0 and 3. Even in category 3 bite re-exposure, you need not give monoclonal antibodies or immunoglobulin. It is enough if you give 0 and 3. This full course of vaccination 0, 3, 7, 14, and 28 will give you lifelong protection. For every re-exposure, you need to give 0 and 3. Is it clear? Yes, thank you. Now I request Dr. Suresh Kumar, my fellow faculty in pediatric infectious disease certificate course of IMA, to deliver his lecture on adult vaccination. Thank you, Dr. Singarwal, sir.
Thank you, sir. Thank you.
Thank you. Dr. Suresh Kumar.
Sir, I want the video to be open up there. Am I audible first?
You are audible, sir. Your slides are visible,
Your
sir.
video also,
Okay.
no.
Video is not like not able to say video, not able to direct the camera.
Okay.
Sir, your screen is seen, sir. You go through with your slides, sir. You go to the next slide, yeah. You go to the next slide, sir.
Okay, sir, no problem. I'll do the thing.
Yeah.
This is the before disclosure. Thanks for the wonderful opportunity. I sincerely thank the Dr. Sendil for giving this wonderful opportunity as his organization. And I thank the chairperson for introducing me. So what I'm going to do in the next 20 minutes, that's what given time there. So what I'm going to do next 20 minutes, I'll go to show, this is called ID grand rounds, I put it there. ID grand rounds means difficult cases, what we encounter, not difficult cases, common cases, how the ID doctor will think about it. I'll let you know there. So this is a poorly hearing specialty. Before that, my disclosure, this is infectious disease is a poorly hearing specialty, but we try to solve the problem created by most of the other specialty, but we don't make money. So before that, what I do is I want to run a small poll, just check whether the poll is running or not. I just check 1 second. 1 minute, stop sharing this one. So what I do, I run a poll. Sorry. Yeah. So this is a poll I'm starting. You just see the QR code. I think it's visible to you. Whether you can able to see and access this one, just check. Otherwise, we can go back and see the problem one. The poll is visible to you people?
QR code is not visible, sir.
Oh, QR code is not visible, but we are able to see, but you're not able to answer. Okay. Yeah, right now any QR code is visible. Right now, no. Okay. Okay, leave it there. So I'll do something then. I started, but unfortunately, I didn't do. Okay, fine. I'll do one thing. Come back to my presentation there. Yeah. Sorry. Zoom. Okay, I'll come back to my presentation still there. So hopefully, like I'm asking how many people are vaccinated in the last 2 years. Just put it in the chat box. I thought of running a poll, but unfortunately in Zoom, it's not possible right now. So how many taken any vaccines in the last 2 years? Just go ahead and put it in the chat box so that we can count it and see. Although 998 people are sitting right now, I want to see how many people really taken the vaccination as a doctors there. Just I want to check. Just go ahead and put it in the chat box right now. Okay. So we can discuss at the end. A lot of messages is coming up. That's a good news that people are active. So my objective is ID grand rounds means we are discussing an infection related or vaccine related questions. I'll come back why the grand rounds is important. Not my objective. Before that, what happened? Before COVID era, if you search for adult vaccinations, this image comes there. Adults are giving vaccination to the children. That's what my previous speaker and previous moderator used to do. They give vaccination to the children. But half late during the COVID time, doctors, they themselves take the vaccinations, and most of the people, they take vaccinations and immediately put in the Facebook and Insta, showing that we are vaccinated for COVID. That pride was there. But unfortunately, after the COVID has gone, I'm not sure how many people voted in the chat box. I need to say how many people take the vaccinations. They mentioned COVID means in the last 2 years, COVID vaccine is not available. So they're not recognizing what vaccine they have taken and what timeline also. They just forgot about it there. So this is my miss. Again, switching back to the COVID era, we need to take adult as a vaccination, not only COVID vaccinations, all sorts of vaccinations. I'll come back now. So this is my grand round case 1. 55-year-old male, newly diagnosed diabetes mellitus, is known asthmatic. Person is a systemic hypertension and underwent master head check. MHC is master health check. His HbA1c is 11.3. Other system examinations is normal. ECG, renal functions, LFT, exchanges is normal. Taking metformin, glimepiride, and telmisartan. Recently started, and inhalers also. But he said, based upon the master health checkup, I just want to change my prescriptions. He doesn't want any vaccination. He just wants the prescriptions for the diabetes, hypertension, and bronchial asthma. What will you do now? Previously, I thought of putting a poll, but unfortunately, my QR code is not visible. So change his prescription. So many say just change the prescription. That's what he came for it. The sugar is not under control. Assess the eligibility for the vaccination alone. Some of the master health checkup, they won't provide vaccination. They just assess eligibility alone. Or administer the vaccinations for the person who needs some vaccinations or not. Or some suggest the vaccinations, let him take it. Whether he want to take it or whether he ignore it, that's his option. Or refer to the pediatric doctor who was speaking previously. They are good in vaccinations because adult physicians, most of them, they're not good in convincing the people to take the vaccinations. Just go ahead and put in the chat so that we can discuss at the end. I just want to see how many people are answered the thing. Okay. So why adults need to take a vaccination? This image tells the story. For example, when the newborn is born, I do pediatric ID too, but when the newborn is born, they don't have any immunity for most of the diseases. Whatever immunity from the mother as a passive immunity that's going to last for 3 to 6 months, that immunity is not going to protect all the infections. So the immune system starts developing from the age of 5. It reaches in the peak in adulthood, and as age progresses over the age of 50, that's called immune senescence. That means the immune systems won't react what it was reacting in a younger age group. So it starts again behaving like a child. That is why we'll say we'll start as a child without hair, without teeth, and with diaper, and ending the life without hair, without teeth, and diaper also. This is a status of both young as well as old age group. The old age group is very difficult to define. Some people say 50, some people say 65. But what the pneumonia literature shows, people above the age of 50, the chances of death is 2.5 times higher. That means if the death is less than 50 years for a pneumonia patient is 14%, means above the age of 55, it is above the age of 50, it is almost 35%. 2.5 times is a risk of getting death following pneumonia. How the children are vulnerable to the death, similarly adults also vulnerable to death. This is a point. But fortunately, children, the pneumococcal vaccination is prescribed routinely nowadays, so most of the children are saved nowadays. Then people ask, you are saying that yes, adults are losing their immunity, but what is the point? What is the benefit of having vaccinations? So this is a typical benefit of the vaccination to me. Some of the diseases like smallpox is almost eradicated now. There is no smallpox we are seeing. In fact, the vaccination is abundant. We can find the age of you, whether you're born before 1980 or not after 1980, by just checking your left upper limb. We can say whether the big scar is that you're born before 1980. After the 1980, the vaccination is abundant. Similarly, tetanus cases. We see a lot of tetanus ward. I worked in a tetanus ward in undergraduation. But right now, none of the medical colleges, I'm talking about government medical colleges, they don't have tetanus ward. Similarly, while studying at the undergraduations and school time, one of my colleagues was a polio affected person. But right now in my daughter or granddaughter classes, there is no person infected with polio is walking around. So this is a status of the vaccination that eradicated or eliminated so many diseases, and some of the diseases are verge of elimination also. That's possible right now because of the vaccination. The point here is vaccinations prevent a lot of diseases, eradicate a lot of diseases also. That's the point one. Then people say, I don't want eradicate, eliminate. These are all public health approaches. As an individual, what is the benefit of vaccinations? You can ask me. So this is a beautiful American Journal of Medicine paper. It shows there are 10 secrets of long life. People want to live longer. People want to live healthier also. What are all the 10 suggestions? Among the 10 suggestions, 1, don't take antibiotics. Use public health like clean water, clean environment, everything is fine. But vaccines. If you take vaccines and avoid antibiotic, you can live up to the age of 100 to 115 years. So this is advantage for individual persons, not only for the public health, but individual persons. You are going to stay for 110 to 115 without major diseases with good quality of life as this is possible to you. So coming back. So my first part is why we need to take vaccinations. Why as an adult physicians, we need to tell the people vaccinations. 1, it prevents a lot of diseases. It saves life. And most important thing, it gives quality of life to you. Then second thing is now what vaccines I need to. You decided you to counsel the patients. The patient is willing to you now. So what vaccines you are going to recommend right now? So can you tell again, go back to the chat box so that we can discuss. How many say this person needs only influenza vaccinations? How many say pneumonia vaccines? Shingles, hepatitis B. all of the above. Always MCQ says all of the above, none of the above, people always get tensed up. So go ahead and vote so that in the chat box you can put it right now. Unfortunately, I didn't have a voting system working today, but fortunately you can have the chat box. So go and put in the chat box. Based upon the chat box only, we think what do you call your TNMC credit points we can think about. People say all of the above. In a conferences, we ask the thing, they say all of the above. As an adult, you are taking any vaccination, they say no. As a healthcare person, have I taken the vaccination? They say no. So this is a conference type of answers only we are expecting there. But what we expect at the end of the presentations, in real life also we need to do. That's our aim of presentations. I understand people put 5, 5, 5, get the marks there, but getting marks is not immaterial to you. So as an adult, what approach we usually follow? Pediatrics is easy. As an adult, what we need to do, the approach is called HALO. What is HALO means? I'll come back and explain in a minute later. But this is the latest CDC 2025 guidelines says what are all the vaccines adults supposed to take. This is from the age of 19 I'm showing, not below the 19. This is adult group vaccination recommendations only I've shown here. And this is for disease specific recommendations on the same organization. If you got like diabetes, if you got like coronary heart disease, or if you got a CKD, CLD or pregnancy, what you need to do. So this is called the HALO. HALO means health factors. For example, the person is a diabetic and the person is a COPD, CKD, CLD, what vaccinations pertaining to particular diseases. Second thing is an age. Again, age is a number. People say always 50 for vaccinations. For other thing, they always put 65 or something. But as far as a vaccination is concerned, the magic number is 50. Why? Because the paper has shown the pneumonia, the death rate goes more than 50 years. The death rate is 2.5 times there. The third thing is a lifestyle. For example, whether you are living in a, we are eating, for example, young people, they're eating most of the time pani puris. What disease they're going to get? Hepatitis A and typhoid is possible. Occupation, as a healthcare worker, we need to take certain vaccinations. People similarly going to certain lifestyle practices like going to the Hajj when a large crowd is happening, what we need to, or Kumbh Mela. So we need to think about these diseases also. And some of the occupation like veterinary doctors, they're vulnerable to certain things. Even nowadays, courier boys or person working in IT sector coming late or coming early in the morning, almost all the street contains dog chases individual persons coming in a two-wheeler or by walking also the chases, and children, they're vulnerable to the street dogs. So this is why called the lifestyle, this is called the occupation also. So coming back to the thing, people always say why influenza vaccinations for people with comorbid. Influenza without comorbid, the chances of going for a pneumonia, going for ICU stay, going for ventilator is less. But if the person has got comorbid condition, the chances of influenza causing a severe pneumonia, causing a ventilator-associated pneumonia is more on the card. That's the important thing. And the chances of survival also go down. So comorbid persons, without testing also, people start giving oseltamivir. That's more important. For pneumonia, see the last line. Risk increases with not only age, poor glycemic control, chronic kidney disease and COPD, even chronic smoker, the pneumonia incidence is going up. So this is other risk factors we need to consider. And third thing is called zoster. Zoster is always, people say adult vaccinations, why? Certain diseases are not common in the children. For example, shingles is not a common in children at all. This is common adult problem. So we need to give the vaccinations. Then people asking about why diabetes and hepatitis B vaccination. For example, CKD and CLD, we are putting hepatitis B vaccination. Why? A lot of blood-borne exposure is there for CKD patients and CLD patients. For a diabetic also, we need to have more number of glucose taking happening, more hospitalizations, lot of diabetic food handling and everything is happening. So hepatitis B is mandatory as per American Diabetic Associations and most of the guidelines also insisting. So for a vaccinations with the comorbid indicated. Why? Because the chances of getting severe disease, chances of going to the ICU, the chances of death is very high. That is why people with comorbid conditions, they need to be protected against whatever vaccine preventable diseases, they need to take the vaccinations. In short, what are the things? They're supposed to take influenza vaccines every year. They need to take pneumococcal vaccines. Ideally nowadays, the conjugate pneumococcal vaccines available, 20 serotypes are covered. Then tetanus and diphtheria, yes, once in 10 years, Tdap, but after that, once in 10 years, TD is fine. Zoster above the age of 50 years to avoid herpes zoster and shingles that causes terrible pain to you people there. Then what is the differences between one vaccine? For example, influenza previously live attenuated vaccines and killed vaccine, but right now killed vaccines is unavailable. And similarly, the 3-valent and tetravalent, quadrivalent is available. Right now, 3-valent is available, is useful compared to quadrivalent because one strain is almost washed out according to the couple of surveillances of WHO. As far as pneumonia is concerned, there are 2 vaccines are available. One is called conjugate vaccine, other is called polysaccharide vaccine. What is the differences between conjugate and polysaccharide? The conjugate vaccine has got good memory. Polysaccharide vaccine doesn't have memory. Previously, the conjugate vaccine only 13 serotype, and now conjugate vaccine has got 20 serotype. So almost matching to the polysaccharide. So it has got very good memory. So this is a drug of choice, or this is a vaccine of choice for anybody who has got pneumonia. Previously, people say between the age of 2 to 50 years, there is no good data for the conjugate vaccines. But off late data is emerging. It is safe only. There's no contraindications. Even in adult population, this vaccine is recommended now. So coming back to this case now, second case I'm putting. First case I told why we need to vaccinate. Adults also need vaccination because of the immunity is going down, one. And second thing, lot of diseases can happen in adulthood like herpes zoster. And then think vaccines are protecting, vaccines are saving the lives. And how we decide about it, halo approach. What health factors has got it, what is the age, what is the lifestyle, what is the occupations. And people with comorbid, they are vulnerable to severe disease, so they need to be protected. Now, my second case here is a grand round case. This is a 26-year female, 2 months pregnant. Father developed herpes zoster. 3 days back, the father developed, and she stayed with first day with the father. Next day, he went to her husband's place. No fever, no rash. On examination, she is normal. What would you do now? This is really, I wanted to check people what we are going to do with this patient. How many say start varicella vaccine immediately? Because that gives a lot of protection to the persons. Because here also I give none of the above, not all of the above. So I'm just checking how many people are answering. People say varicella IgM we can do right now. Varicella IgM is synonymous thing there. So they're saying varicella IgM. I tried to confuse you people. I'll come back to this case a little later part of it there. But not only vaccines prevent the diseases, even after the exposure. For example, hepatitis B, even after the exposure will work. Varicella, even after the exposure will work. Similarly, hepatitis A, even after the exposure will work. So these are all the vaccines. Not only before the exposure, even after the exposure, it will work. That's called not only pre-exposure, as a post-exposure also, a lot of diseases can be prevented. That's the bottom line here. But most important thing, pregnancy. People say varicella IgM to check, but nobody say varicella vaccines. Why? Varicella vaccine is a live vaccine. We need to know what are all the vaccines is live vaccines, what are all the vaccines is a killed vaccine. So for example, oral cholera vaccine is a live attenuated, MMR is a live attenuated, nasal influenza, live attenuated, varicella, oral typhoid, oral polio, yellow fever. These are all the vaccines never give. In addition to this one, even though one killed vaccine is called human papilloma virus, because of this cancer related one, people are doesn't give in the pregnancy time. So live vaccines are contraindicated the pregnancy time. So to avoid, but suppose a person has got not telling he is pregnant and received the vaccinations, what will happen? So far, the huge vaccine registries followed the patients. Nothing has happened. Nothing has happened. That's more important for the thing. But try to avoid, because theoretically it can cause infection to the fetus, can cause abnormalities. But in general, don't give the vaccinations for a pregnant lady. If suppose inadvertently given, you can follow the persons. If it is a precious pregnancy, don't need to go and terminate the pregnancy. It's not required. Large vaccine registry showed it is safe only. This is the bottom line here. Then this patient, after receiving you, went back home, bitten by a dog. So what are going to do now? So the person has got a pregnant 2 months, now bitten by a dog. What are going to do now? Please go ahead and vote so that we can have a discussion. People say, how many people say just wash and wait, finish the first trimester, then take TT alone or rabies vaccine or take rabies, TT, everything they want to know. People are interested in getting credit points by putting name and everything, but people say 5. Choice 5 is unanimous here. Most of the people say 5 there. This is another time for 5, I do not know. So the problem is people always say first trimester is dangerous, I know. But as far as pregnancy is concerned, there is no timeline also. Particularly this type of vaccines, we need to protect. This is a category 3 bite. In fact, people have suture also. So live vaccines is contraindicated. Killed vaccine, there is no contraindication. Ideally, try to avoid first trimester. That's why people always put the TD and TDAP either from the 16 to 24 weeks or up to 32 weeks. Try to avoid the first 12 weeks. But killed vaccine, there is no contraindications any point of time. Rabies vaccine is a killed vaccine, and this is as per the CDC guidelines. What are all the vaccines we can give? Live attenuated vaccines are not indicated. All the killed vaccines we can try, and rabies belongs to killed vaccines. There is no problem in giving in killed vaccine. So if the person sustains some dog bite, instead of suffering a rabies, we can give the protection to the person. So now the problem is changed. After 2 weeks, the father is coming back. After finishing the herpes zoster, all the lesions are healed. He asked you, doctor, can I bring my daughter? Because the month of Hadi started, July 15th onwards, Hadi started now. So they can bring them like a newly married couple for their parents' house right now. But the person is a diabetic and splenectomy happened 10 years back. During the splenectomy, some doctor has given some vaccinations for the father. but he has not taken COVID vaccinations. He has not taken any other vaccinations now. Sorry for the spell check. So yes, stay with the doctor, not stay with the doctor. Then you want to start with the daughter only there. So no herpes zoster will come back. Give shingles vaccine plus pneumonia plus flu shots in refer. So this time I put incidentally 5 also. How many people still voting for 5? I just want to check that because people always put 5 as a favorite number. For this questions, what is the recommendation? Father suffered zoster, recovered from the zoster. What will you do for the father? So whether the person can live with the daughter or not, this is a question to you. Usually herpes zoster can transmit the chicken pox. So people say give herpes zoster, no herpes zoster will come back. So you want to give the vaccinations. So this is what people are talking unanimously. So how to solve the problem? Usually the person exposed to herpes zoster, what we need to check here, we need to check the varicella IgG, whether the person has got previously exposed to varicella or not. The person already got varicella IgG is positive, no need to worry about herpes zoster because herpes zoster reactivation disease. Once you had chickenpox and younghood, once you become older, more than 50 years, where herpes zoster can happen. Herpes zoster won't transmit herpes zoster. Herpes zoster will transmit varicella. So to know whether the person is immune or not, we need to check the varicella IgG. IgM is not correct, so none of the above is the correct answer here. And here what happened? We need to give the vaccination because the person is pregnant. This is a killed vaccine. So you can give TT, you needed rabies vaccinations. This is a category 3 bite, either human rabies immunoglobulin or monoclonal antibody. And this year we need to give the fine. Here what we need to do, the herpes zoster is healed, but herpes zoster can come back again. 10% risk of coming back is again is possible. So we need to give vaccination for the person who recovered from the herpes zoster to prevent the suffering. And herpes zoster produces a good level of immunity. There's no need to worry about it. You can't say I had, for example, if you had chicken pox once, you're not going to get the chicken pox again. But if you had herpes zoster, you can have multiple times herpes zoster is possible. Particularly if you're immunocompromised, the chances of getting herpes zoster multiple times is very high. Since a person is pregnant now 2 months only, at the delivery time again, one more herpes zoster for the father can cause a disasters for the family. So better to give vaccines to prevent herpes zoster recurrences again. So this is my last case here, 24-year female. She's working in a NICU, NICU, neonatal ICU, and the person is staying in a hostel. Person claimed at the time of joining hospital, we asked any vaccine, any varicella in the childhood. She said, I had chicken pox in my childhood. But this is a skin lesions. I put the forehead part of the nurse. NICU has got 6 preterm baby. All are 28 and 32 weeker. One extreme preterm is the resident 28 week is also there. 4 preterm discharged in the last 10 days. By the time they exposed to this fever with skin rash nurse. 12 nurses and 4 doctors managing the NICU. What would you do? This is a real case because I heard some of the pediatricians are still sitting back. So you can solve the problem here now. What will you do? Offer all persons medical leave. Seen or all the varicella check or give varicella immunoglobulin for all the newborn. Monitor and expose signs for the varicella. Don't tell because this is a big headache for the thing. People also want to check the varicella IgG. Again, number 5 is coming back. So they want to give acyclovir to all the above. None of the above people are not trying. People say do varicella IgG plus give immunoglobulin also. That's what people are talking about. That's a good thing that people are actively participating. That's a good news. So always says patients can transmit disease to the healthcare worker and healthcare worker also can transmit the disease to the patients. Both are dangerous in healthcare worker and patient will transmit the disease to other patient also is possible right now. So what we need to do right now. So this is a real case scenario. We published in ICMED one of the conferences abstract. What we did, we checked we given varicella immunoglobulin. That's the recommendations. Extreme preterm, even though mother has got varicella IgG, we need to protect the immunity by giving a varicella immunoglobulin. But fortunately, that time the varicella immunoglobulin was available. But only all newborns has got varicella IgG is positive. But extreme preterm, we have given a varicella immunoglobulin to the extreme preterm, even though the extreme preterm has got a varicella immunoglobulin. So hereafter, what happened? The policy of hospital has changed because the nurse told at the time of joining he had chicken pox. But he had got some rashes to refuse the vaccinations. He told I had chicken pox in my young age. We didn't check the varicella IgG. Nowadays, we changed the policy. Anybody coming to the hospitals, joining a healthcare worker, we need to check the varicella IgG. IgG is positive, they can continue to work. IgG negative, take the vaccines in your hospital. Otherwise, varicella exposure is a big headache for the hospitals. So we category changes there. Hepatitis B for all the patients. Varicella, particularly for a newborn working area, pediatric ICU, emergency, labor room, we need to give it. Influenza for most of the people, ideally in critical area is required. TD, yes, it's good for you. Typhoid for people working in a canteen area and food handlers. MMR again, pediatricians supposed to take. Right now, measles outbreak is going across the country, and more across the country, across the world. US has got a big measles outbreak. So based upon the vaccinations, we can change the policy also. So why vaccinations for adult? To prevent the outbreak, to improve the health of the persons, to prevent death of the patients, we need to give the vaccinations. How to set up the adult vaccinations clinic? Most of the pediatricians, they give it a clinic itself. But adult, we got a separate vaccine clinic, nothing but one nurse and one clinical pharmacist, and it is in our OP itself. So any reactions, we can go and tackle it there. This is called the vaccine room. We are giving almost 12,000 to 15,000 vaccines in a year. This is a huge adult program. So in summary, all adults need vaccination. Use halo approach. Health, patient's age, lifestyle, occupations. Live vaccines are usually contraindicated in pregnancy and immunocompromised. Hospitals should have a clear policy. Vaccines won't save the lives, but vaccinations save the lives. These are all the doctors who lost their life during the COVID wave 1. Why they lost the wave? Because there is no COVID vaccines. Probably with the COVID vaccines available at that point of time in 2020 June, a lot of lives would have been saved. Unfortunately, there is no vaccine at that point of time. They lost their life. So we need to know how to save the life. This is a critical classic example. The person can save life if you take vaccinations. That's a bottom message I'm giving. In summary, if you're above the age of 50, take flu vaccines, pneumococcal, zoster. If you're diabetic, take hepatitis B. If you're healthcare vaccine, particularly we need to take flu. A lot of measles is roaming around. Take measles vaccinations, hepatitis B, and you need to take TT and varicella zoster if you're not had chickenpox. Pregnant women take flu and pregnancy, and Tdap is required. If you are going for a college or if you're going for higher studies, better to take meningitis or MMR vaccination that's required for you. I'm happy to take any questions for vaccines and antibiotic envying about the vaccinations. If you want to know more about antibiotic algorithms, newsletters, everything is available. Keep this WhatsApp number. And most important thing, this ID Grand Road CME is coming on August 15. Almost all typical cases, what I shown now. One case and how to approach what is ID principle. This is what we are doing. This is an hybrid event. Those who are joining in Chennai, they can join and participate. That time, definitely I agree. Your voting pad will work and you get certifications at the end of the examinations. Almost 30 cases we are going to discuss. Those who clear the exam, they get certifications at the end of it. So this is the first advertisement we are giving it. So just the ad will be circulated in other subsequent things. Anything, you just WhatsApp this number. Thanks for the wonderful opportunity joining in Chennai on August 15th. This Independence Day. You can get independence from whatever difficult infections you are dealing with it. You can get away with by joining the CME. Thanks for the opportunity.
Ready பண்ணியாச்சாமா?
Thank you, Dr. Suresh. Thank you. So, Suresh, please be on the line. We have Dr. Shamala, who has accidentally gone out of the meeting. Now she has also joined. She will complete her slides in another 10 minutes. At the end, we'll have question and answer session for both adult and pediatric. I request Dr. Shamala to join. Shamala, you can share your slides. Dr. Shamala?
Yeah.
Please share your slides. Suresh, please be on the line.
Yes, sir.
Once Shamala is over, we can have discussion.
Sure.
We can collect the questions. Dr. Sadish, you are there? Dr. Sadish, sir?
Round of appointment continue.
Okay. At the end of both the vaccination, we can have question and answer session on vaccines. Yeah. Please continue with, please be brief, madam. Please complete within 10 minutes. Yeah.
About that, I didn't realize I was cut, so I actually finished my talk. So some of the slides, I think Suresh has covered. So I will briefly,
I stand on.
Yeah, thank you. Yeah, please go ahead. Please go ahead, madam. Please unmute and go ahead. You've been muted. Please unmute and go ahead. Shamla, madam, you've been muted. Yeah.
Can you hear me now?
Yeah. Please go ahead.
Okay. So Suresh has already covered some, so I did not realize I completed my talk without knowing that I've been cut off. Okay, so just here is in brief the national immunization schedule, which is followed in government hospitals. So starting from pregnancy, 2 doses in the pregnant woman, BCG at birth, hepatitis B and OPV at birth, pentavalent vaccine, which is DPT, Hib, and hepatitis B again at 6, 10, and 14 weeks. Rotavirus again 6, 10, 14 weeks. And IPV, which is given in a different way in the government hospitals because there is a shortage of injectable polio. So this is given intradermally at 6 and 14 weeks. Normal dose is 0.5 ml. So in the government hospital, they receive 0.1 ml at 6 and 14 weeks on the right upper arm. So in the government hospitals, they don't cover mumps. So only measles and rubella first dose at 9 to 12 months, Japanese encephalitis 9 to 12 months, booster for DPT at 18 months, measles booster again, OPV booster given along with DPT, JE second dose, DPT booster repeated at 5 to 6 years. And TT is given at 10 and 16 years. In the private sector, we do differently. So this chart shows what is recommended by the Indian Academy of Pediatrics. So here the difference will be that we give PCV, also pneumococcal conjugate, at 6, 10, and 14 weeks and a booster at 15 months. And we give MMR, mumps, measles, and rubella. And hepatitis A is given at 1 year and 6 months later. Varicella is also given. Chickenpox is covered, 2 doses, 3 months apart. And Tdap is given in teenagers, not just TT. And now even the UIP schedule includes HPV, human papilloma virus vaccine. Single dose is given to all girls at 14 years of age. Meningococcal vaccine is again given to high-risk individuals and also JE. The spacing between vaccines depends on whether it's an inactivated and a live vaccine. So 2 vaccines can be given simultaneously, but at different sites. Killed vaccines can be given simultaneously with a 4-week gap, and 2 live vaccines can be given simultaneously. Otherwise, there should be a gap of 4 weeks. And the following are not contraindications: mild febrile illness, diarrhea, prematurity, or current antibiotic therapy or malnutrition. So specific precautions need to be given. Suppose the child has received immunoglobulin following Kawasaki's disease or GBS, for example, we should not give live vaccines to the child for at least 9 months. Avoid pertussis where there have been neurologic events following the vaccine, DPT vaccine. And if you suspect immunodeficiency in a family, we avoid BCG. And in some conditions, you give prophylactic vaccines only after exposure, like rabies, like what Suresh was discussing. A little bit about individual vaccines. I already mentioned about polio. What I wanted to mention is oral polio is actually bivalent only. There are 3 types of polio virus, but the oral polio covers only type 1 and type 3. Because type 2 vaccine, type 2 virus, we don't see disease from that. But IPV protects against type 1, 2, and 3. So it's important for all babies to get at least some kind of IPV vaccine. DPT, both cellular and acellular vaccines are available. There are some controversies, but again, it depends on parental acceptance. In the government, what is given is the whole cell pertussis vaccine, which is painful, causing a lot of local side effects. The acellular pertussis vaccine, DTaP, is given in the private sector, lesser side effects. These are some of the acellular pertussis brands that are available in India. Based on the age, you can choose which one you want to give. Pneumococcal vaccines, again, very important to prevent pneumonias, meningitis, otitis media, etc. The polysaccharide vaccine is used only after 2 years, that is PPSV 23, whereas the conjugate vaccines have good efficacy in infants also, because they are conjugate. The pneumococcal protein is conjugated to toxoid and elicits a good immune response. Typhoid vaccine given in the private sector, but not in the government. We start as early as 6 months. And MMR vaccine, I told you, mumps, measles, rubella covered in the private sector. Hepatitis A at 1 year. 2 brands are available. Chickenpox vaccine not covered in the government sector. We give 2 doses at least 3 months apart in the private sector. Flu vaccine is optional vaccine. Again, we give to all infants at 6 months and 7 months of age. And also annually up to the age of 5 in the high-risk season, that is in the rainy season. Pneumococcal vaccine given to high-risk babies. In the encephalitis, now we are given even in Chennai, 2 doses 1 month apart. And HPV vaccine, I told you already, it's being given in the government only for girls, but in the private sector, we've started giving also for boys, because not only it protects against cervical cancer in girls, it also protects against genital cancers, oral and nasopharyngeal cancers. The new kid on the block is a monoclonal antibody to RSV. And we see respiratory syncytial virus infections in high-risk preterm babies, in those with congenital heart disease. and preterm with chronic lung disease, etc. So you give it to high-risk infants less than 8 months of age. Again, the peak incidence occurs in the rainy season from August to January, February. So this is the time you can give them the first dose. There's no indication for monoclonal antibody after 20 months of age. Special circumstances, preterm babies less than 2 kilos, we avoid giving hepatitis B vaccine. In children who are on steroids for nephrotic syndrome receiving at least 2 milligram per kilo or 20 milligram per day of steroid, you should not vaccinate, especially live vaccines. And if any immunosuppressive drugs or biologics, then you must avoid vaccination as long as they are on this therapy. In children who are to undergo splenectomy, you give them encapsulated organism vaccines like pneumococcal and meningococcal vaccine. You start at least 2 weeks before the splenectomy and supplement with another dose a month later. Adolescent vaccines, I think Suresh is partly covered. Tdap booster we give around 10 years. HPV I already mentioned. In children traveling abroad, especially to New Zealand or US or Canada, they ask for a meningococcal conjugate vaccine. And catch-up vaccines, if not completed in childhood, you have to ask and give hepatitis B, MMR, varicella, and hepatitis A. Especially if children going for medical college or any health-related carriers, they have to check their hepatitis B immune status and give a 3-dose series and recheck the immunoglobulin, the antibody response. Rabies, I'm not covering. Yeah, just a little bit about the cold chain. We have to make sure that our vaccines are kept at the right temperature because a cold chain break can rob a fully administered dose of its protective effect. So commonly what's used in our clinics are the ice-lined refrigerators. Make sure that the electricity supply is unimpeded, and this grades the heat sensitive vaccine. Oral polio being the most sensitive and hepatitis B and Hib being the least sensitive. So key takeaways. We have to match the vaccine to the biology. So the killed vaccines, you will have more doses, whereas the live vaccines will be lesser doses. A missed dose, you don't have to restart the entire schedule again. Cold chain integrity is important, and live vaccines need a 4-week gap. And whereas killed vaccines are more flexible, mild illness, low-grade fever, and antibiotic therapy are not contraindications for vaccine. And the last, no vaccine is 100% effective. Sorry about the mix-up. I didn't realize that I was cut off. So I had already done my talk without knowing I was offline. I am happy to answer any questions you have.
Thank you, Dr. Shyamala. Thank you, Dr. Suresh. Both of you have completed excellent overview about vaccines. I really appreciate you both. If there are any questions about the vaccinations, both adult and pediatric, you can. If there are any questions, Sandil, you are there. Sadish, you are there. You can open the chat box and see the questions. If there are any questions?
Sir, there is a question about hepatitis B vaccine for adults.
Suresh, answer. Hepatitis B vaccine
that has to be taken in deltoid is given in the gluteal region. Would the efficacy differ? That's the question, sir.
Yeah, please remember, no vaccine should be given in the gluteal region. That's an important message to everybody. So no vaccine, because gluteus in the gluteal region, you got a thick pad of fat. So the vaccine may go into the fat, and the vaccine uptake seroconversion will be very, very. It may not get seroconverted. It may not get protection. So it will. So always it is better to give in the insertion of deltoid in adults. In children less than 7 years, in the anterolateral mid-thigh, in the muscle vastus lateralis muscle. Do not give any vaccine in the gluteal muscle.
One more question from Dr. Bhagyalakshmi, pediatrician. If there occurs fever after the first dose of ARV, can second dose be given on day 3?
Yeah, irrespective of fever, pain, or swelling, anything, whatever there is a local reaction, you have to continue with ARV. You should not stop ARV. It is the fever is not a contraindication for stopping ARV. So you need to give paracetamol and continue with the ARV because it is life or death. It's 100% fatal. or 100% survival. You need to continue ARV. And there was a question, is if there is a drop of blood coming from the bite site or the scratch site, is it category 3? Yes, it is category 3.
Can I mention something?
Yeah.
See, I think it's very important to check all females for rubella vaccine, okay? Because even still now we are getting congenital rubella at times, and it's so painful to see the, the child suffering. So any adolescent girl who's not been vaccinated or who's unsure about vaccine status, kindly offer at least 2 doses of rubella vaccine and ensure that they don't get pregnant within a month of the last rubella dose. So that's one thing I wanted to mention.
Yeah,
and
very valid point. Nowadays, the government also insists they are having the marriage in the government corporation mandapam. They need to have MMR vaccine should be there when they book the hall, marriage hall. That's a very good move, and I appreciate that.
Sir, one more question. Health workers who took all the vaccine by birth as per NIS schedule should repeat the vaccines you mentioned. I think this question goes to Dr. Shamla, madam.
Repeat, Dr. Satish, what is the question?
Health workers who took all vaccines by birth as per NIS schedule,
yes,
should they repeat the vaccines, what you have mentioned? Probably it means that there are other vaccines which are not included in the national immunization schedule. That's what I think the question means, but not very clear.
Okay,
I think the question is, should we repeat in adults? Those who have completed the vaccine as per NIA schedule, should we repeat? Does the immunity last long, or is there a chance that weaning immunity we need to give booster dose? That's a question.
I think it depends on what vaccination they're talking about. There is no need. See, if you're a healthcare worker, definitely I would check the hepatitis B immune status and repeat. If you're an adolescent, definitely I would think about the MMR vaccine, as I said, HPV vaccine. But other than that, I think it depends on the individual situation. So there are some vaccines, if you missed, some vaccine, it doesn't matter. Rotavirus, if you missed, no problem. Hepatitis A, again, if you're, handling food or something, then hepatitis A is important. Or if you're eating out a lot, then hepatitis A is important. I think we can individualize based on the situation.
Yeah, that's a good question, and you answered. Please remember, many of the vaccines, many of the diseases, those you are vaccinated in childhood, there is a waning immunity. Now you see lots of adolescents getting pertussis, diphtheria. So it is better to vaccinate even a healthcare person who has taken the primary vaccination to vaccinate yourself against the Tdap with the Tdap. That's number one. And as Madam rightly told, there are certain illnesses which are pertaining to pediatrics alone, less than 5 years, like RSV virus, rotavirus, oral polio, and pneumococcal. They are all pertaining to children below 5 years. In adults, particularly adults or older doctors, healthcare workers, you need to take pneumococcal vaccine, influenza vaccine, and other vaccines that are as recommended by the government of India. Adult vaccination is must, even if you have taken pediatric vaccination.
Sir, one last question to Dr. Shamla. Can you explain the catch-up vaccination for a 5-year-old child? The child did not receive the second dose of MR as per the schedule at 16th month. So, okay, the child is now aged 5 years. The doctor wants to know the catch-up vaccination.
I think 2 doses of MMR 8 weeks apart. That is recommended.
No. This child has received MR first dose as per the NIP schedule. The 16-month dose was missed. Now the child is aged 5 years. I feel that you can give MR, MMR. No,
it's better to give MMR, sir, 2 doses.
Yeah.
Yeah. Okay. 2 doses.
Yeah. Thank you, Dr. Satish. Thank you, Dr. Shamla. Now I invite Professor Raghunathan, sir, who is traveling from Pondicherry to Chennai to give his lecture on typhoid and scrub typhus. Raghunathan, sir.
Thank you for the opportunity.
Thank you, Dr. Shamla.
Good evening, sir. Thanks,
Good
Dr.
evening.
Neminathan, for your introduction, sir. I
Yeah.
thank the IMA office bearers for giving this opportunity, and also my special thanks to Dr. Sendil sir for asking me to share this presentation. Actually, they have given me two.
Share your slides.
Yeah. Is it visible?
No, sir.
Just a minute, sir. Will you?
Yes, sir. Now it's visible.
Yeah.
It was visible. Now it disappeared.
Is it visible, sir?
No, sir. For a brief second, it was. Yes, sir. Now it's visible. Now it's gone. Gone, sir. Yes, sir.
Is it
now it's visible? Yes, sir.
visible? Yeah. Slide.
Now disappeared, sir. Yes, it's visible now.
Is it
Yes, sir. Visible.
visible now?
Yes, sir.
Is it visible?
Yes, sir.
Yeah, thank you, sir. So we'll start without wasting time. Actually, the two topics that were given to me were both a big one. So considering the time, I'm going to just highlight the three important factors, what we call it as sharing evidence, experience, and knowledge. And I'll ask Dr. Sendil sir to share the slides to the learners also later. So first, I will start with scrub typhus. Actually, whenever we talk about infectious diseases, we always think of typhoid, malaria, dengue, and other things. But scrub is another common problem that we see in our practice, especially in few districts of Tamil Nadu, I would say, because in Chennai, Coimbatore, and Vellore, Krishnagiri, Dharmaburi belt, we have seen a lot of scrub typhus cases. Why this is very important is many times we see it is a mixed infection also in our practice. So I'm just projecting this picture. Whenever we say scrub, we always mention about Eschar. But Eschar alone is not the diagnostic features. We are going to see what are the other things that we can mean. Again, scrub typhus is a zoonotic disease. In fact, man is an accidental host. Just like leptospirosis, also it is an zoonotic disease affecting the rats, and incidentally, man gets infected. Similar to that, man gets infected, and you can see the causative agent and the vector. And this particular slide clearly mentions the natural cycle is among the rodents, but man gets accidentally exposed whenever he goes towards the bushes and other things. So what has happens? What are the risk factors just now I mentioned, especially agricultural exposures to rubber plantation, rice fields, and also during camping, rafting. Why I'm mentioning all these things? When you are getting the history from the patient, as he got exposure to these type of risk factors is very, very important in our day-to-day practice, and also it can affect the neonates as it can transmit it from mother to child presentation. Before I go to the classical presentation, you have to know where to look for Eschar, because when we say Eschar is a diagnostic feature, only 40 or maximum 50% of the cases only we are able to identify this Eschar. But normally Eschar appears in places where we do not normally examine. For example, it is commonly seen in the axilla, under the breast tissue, in the groin, or in the external genitalia. That is why when you are examining a patient with acute febrile illness, when you want to look for Eschar, you have to do a detailed examination. I'll show some of the rare sites where it can occur. So these are the very atypical sites. Now we'll come to the practical approach to a case of scrub. Normally, if any acute febrile illness comes to our practice, we have to identify the duration, what we call it as natural history of the disease. For example, when you talk of dengue, the natural history is around 12 days. But when it comes to scrub, it is almost a disease of 2 weeks duration, and almost a fever persists for almost 1 week. So the common symptoms which will make you to suspect scrub typhus, number one, of course, fever with rash. I already explained about the Eschar, and lymphadenopathy. Again, around 40% of the cases they can present with lymphadenopathy, and cough. And friends, for each infectious disease, there is a unique complication. So as far as scrub is concerned, one of the classical complication is ARDS like picture, which can occur in the second week of diseases, which we'll see. So they can have cough, rash, which I already mentioned, headache and diarrhea. These are the frequency of symptoms. So when the patient comes with prolonged fever of around 1 week duration, if the patient is not diagnosed or treated properly, the fever can continue to the second week, where it's a week of complications. So there are some unique complications that we see in our practice. So we'll go system wise. Most common is they can have slurring of speech and tremors, deafness. So whenever an acute febrile illness comes with deafness, acute deafness, always think of possibility of a strep typhus. Next, of course, they can have CNS involvement in the form of seizures and coma, which are not very common. Next is, as I said in my first thing, respiratory ARDS like pictures. We have treated in our practice lot of patients coming with severe ARDS picture. They have been wheeled into our intensive care units, and the one wonderful drug which can really treat or save the patient is our doxycycline. And today we have IV doxycycline also. We have treated so many ARDS pictures, comes in a very critical state to IMCU, and early treatment with IV doxycycline for a 2-3 days makes a patient so happy he can just walk out of the IMCU. So any acute fever with ARDS like presentation, think of possibility of a scrub, because which is easily treatable. So it can show the pulmonary infiltrates and classical ARDS like picture. Coming to the cardiovascular involvement, it can cause myocarditis, congestive cardiac failure, and relative. I think we are going to talk about typhoid also. So acute febrile illness with relative bradycardia, think of two possibilities. One, it could be a typhoid or it could be a scrub typhus, which we have seen. So other rare complications are acute renal shutdown, shock, and DAC. Even though DAC is more common, we have seen with lepto and other hemorrhagic fevers, rarely we have seen in scrub also. So investigation, as far as investigation is concerned, I think Dr. Surya Kumar is going to cover. So I will not go into detail of this, but any acute febrile illness, rash with thrombocytopenia, we have to rule out. One is dengue and chikungunya, other is your scrub typhus, and third is your leptospirosis. So these keep three things in our differential diagnosis. And as far as treatment is concerned, I already mentioned about that. They respond very nicely to doxycycline. So only restriction for doxycycline would be children less than 8 years of old, or in pregnant women we cannot use doxycycline. So for them, we can use azithromycin, and we also used rifampicin can also be used. So these are the two important life-saving drugs that we use to management of scrub typhus. So to put it in simple terms, scrub typhus is still a common problem in our day-to-day practice, and careful examination and looking for eschar. As I said, eschar is not a must. So absence of eschar does not rule out. So three important features, keep it in mind: fever with lymphadenopathy, acute lymphadenopathy, fever with eighth nerve deafness, sensorineural deafness, and fever with ARDS like picture. Think of scrub typhus, and safely we can start them on doxycycline. Of course, investigation, Dr. Surya Kumar will touch on that. And always think of mixed infection also. Many times, in fact, we have treated three, especially during dengue outbreak, we have treated the same patient having scrub typhus, leptospirosis, and also scrub typhus. So don't forget about scrub as one of your differential diagnosis in your acute febrile illness. So we'll not go to leptospirosis. We'll go to typhoid next as my topic. Typhoid. So as far as enteric fever is concerned, slides are visible, sir?
Yes, sir.
Yeah. So we'll go, it's a big topic. I'll just So I'll just start with, because whenever we are treating enteric fever, we have to have these three probable diagnoses in our mind. One is confirmed, always the confirmation is by your blood culture. But when you're thinking of a possible enteric fever, we have the fever of more than 3 days duration with a positive zero diagnosis or antigen detection test. Nowadays, a lot of card tests have come. And one of the important feature of typhoid as compared to your scrub or lepto or dengue is chronic carrier state. So there's something called chronic dengue or chronic scrub. They are all acute infections and they come out nicely with your management. But one issue with your typhoid is your chronic carrier state. So they are prone for relapse also. And another interesting thing we are mentioned about zoonotic disease. And today WHO has come out with the concept of One Health, where 60 to 70% of our infections are zoonotic in nature. Interestingly, typhoid is only humans carry this typhoid bacillus, and we do not have any other reservoir. And of course, you know all about the transmission like fecal-oral route and other things and all. So these are the three important organisms that we see in our practice. In fact, Salmonella paratyphi A is more common compared to the others, and incubation we know around 5 to 15 days. So the another important thing we have to understand regarding typhoid bacillus is our pathogenesis. Because what happens is after the mode of entry is through the oral route, it settles down in the small intestines. You know, the Peyer's patches are there in the small intestine. So they are phagocytosed by macrophages. And from there, it enters the systemic circulation and it can cause bacteremia. And of course, it can colonize in the reticuloendothelial system of liver, spleen, lymph node, and bone marrow. So what you see the classical in the, again, when I talked about the natural history of the disease, as far as typhoid is concerned, it can go even up to 4 weeks in the natural history of the disease. So I'm just going to explain what happens during first, second, third, or fourth. Of course, it's our duty to pick them early in the first week and manage them adequately so that they don't go to the second or third phase of the disease. So the classical is fever, and you know the step ladder pattern of a classical typhoid. Here you can see the temperature rises slowly, and by the day or 4, 5, 6, it goes to the peak. At this moment, if acute febrile illness comes to our clinic with a peak fever on day 1 or day 2, for example, 103, 104, on even day 1, day 2, think of dengue, because the peak occurs very early in dengue as compared to typhoid, where the peak occurs, it takes around 5, 6, 7 days like that. Again, most important thing is you should know about the gastrointestinal manifestation. It can cause diffuse abdominal pain and tenderness. We call it as rebound tenderness. Sometimes you can have a colicky pain like that. And most important is, as I said, it settles down in the small intestines in the Peyer's patches. So once it settles down in the Peyer's patches, it can cause inflammation. That is why typhoid perforation, those days, no, I have seen surgeons operating for typhoid perforation. Other is your gastric peptic ulcer perforation. Or today, I don't think we are seeing those type of presentation. So technically, they can cause inflammation of the Peyer's patch, and it can cause ulceration, bleed, and they can cause perforation. And of course, it can cause narrowing also, resulting in constipation also. Apart from that, these are very non-specific symptoms like dull frontal headache. Again, the meaning of typhoid. Typhoid means clouding of consciousness. You know, in medicine, most of the terms are Greek and Latin. So those days itself, when they name typhoid, it means clouding of consciousness. So one of the important differential diagnosis, acute febrile illness with delirium, rule out typhoid. Again, it can cause stupor, malaise, and other things. So these are the early manifestation during the first week of the disease. So during the second week, again, it can cause rose spots, which may not be very significantly seen in our population, but cases have been reported like this. Then during the second phase only, you get the splenomegaly. Again, you get a soft splenomegaly. It can have a diffuse abdominal distension. I already mentioned about the relative bradycardia. And again, in medicine exam, we always ask what is dicrotic pulse. So it can have a double beat. The second beat weaker than the first beat. So these are the second week presentation. And if the patient sometimes they move from doctor to doctor, or they may take self-medication. So if the fever continues during the 3rd week without proper investigation or management, they can go to toxemic phase. So they can have anorexia, weight loss, conjunctivitis, thready pulse, tachypnea, and crackles over the lung base, and severe abdominal distension. In fact, I'm talking about 40 years back in Government General Hospital, we used to have an enteric ward separately, where they used to give only waste milk. That is, they put egg in the milk, boiling milk, and they filter it. And because they have to give a soft diet, because all the intestines would have been inflamed during that time. So they can have diarrhea, what we call it as pea soup diarrhea. Again, I mentioned about confusion and psychosis. Again, as I already mentioned, since it affects the Peyer's patches, it can cause perforation and peritonitis. And as I said today, we don't see such a severe cases. Very rarely it can cause toxemia, severe toxemia, myocarditis like picture. Then gradually we may lose the patient. The patient is not properly managed. So again, I was mentioning about the carrier state. That's very, very important. Usually these bacteria settle down in the gallbladder. So that is the reservoir for the typhoid bacillus to be. I think all of us would have heard about typhoid Mary, where she was spreading the organisms without being affected. So we have to think on that thing also. So as far as investigations, in fact, sometimes one of the rarest way of diagnosing, sometimes you have to do a bone marrow culture. And yesterday, Dr. Devarajan sir was telling one of the case, he demonstrated the biopsy of a lymph node from the abdomen. Lymph node was taken and squeezed, and culture was done. So these are a very rare way of diagnosing typhoid, but usually we do a blood culture, which is or stool culture, which we can do in our routine practice. Of course, antibody titers can also be done. So, as I said, I leave the much investigation to my next speaker. So these are the various diagnostic tests. Today, you can even do a stool or a urine culture for that. Sometimes rarely about the aspirate from the duodenum. And we have high-tech diagnostics, all these things are there. So now we'll go to the treatment of uncomplicated typhoid. Today, quinolones are still we are using, or we can go for amoxicillin, which is the next. Or when the patient have a quinolone resistant areas, we can go for the cefixime, or still in our day-to-day OPD practice, still I would suggest even azithromycin really works in our day-to-day practice. So 3rd generation cephalosporins or azithromycin and quinolones can be tried. So when there's a complications, maybe we have to go for parenteral antibiotics, and we should always have a diet is very, very important in enteric. Soft diet, not much of spices, not much of bland diet should be advised. Liquid diets is always preferable, and make sure that we have a close follow-up of these patients. One of the things normally we have eosinopenia in our characteristic report for typhoid. Suppose if the patient has leukocytosis, unexplained leukocytosis without fever or without thing, we have to rule out hemorrhage. They say the patient goes for hemorrhage, leukocytosis occurs. So these are the red flag symptoms that just now I mentioned. Keep a watch over these red flag symptoms of central nervous, cardiovascular, respiratory, musculoskeletal, and other things. As you can see in this slide, any organ can be infected due to, in fact, my chief used to say, all ITs in our body, typhoid can cause as a complications. So these are the common extraintestinal complications that we have seen. Just now I said all ITs are possible in our management of enteric fever. So these are the common clinical features that I already mentioned, and already vaccines has been touched by my earlier speakers. So friends, even though two are very, very important topics, we always believe whenever an acute febrile illness comes to your practice, think of these 5 possible diagnoses. 1, dengue, as can it be a dengue? 2, can it be a scrub typhus? 3rd, could it be a leptospirosis, malaria, or enteric? Keep these 5 differential diagnoses, and each disease has a unique presentation, unique clinical complications based on the natural history of the illness, and every disease has a unique complications that we have to keep it in mind and manage. So, as I said, to summarize, 90% of our patients can be managed as OP. Stay alert, early identification of red flag symptoms, avoid indiscriminate use of antibiotics, be aware of food and water hygiene, and identification of treatment of chronic carriers is very, very important, and vaccination of susceptible host is very, very crucial. Thanks for listening. If any questions, I'll take it.
Sir. Thank you, sir. Now I request Dr. Surya Kumar, the HOD of Microbiology Department of Dindigul Medical College, my close friend, who is also one of the faculty members of the infectious disease certificate course, to discuss about the lab, the clinician's role in interpretation of lab reports on infectious disease, the wise selection and interpretation. Welcome, Dr. Surya Kumar. At the end, be brief. You can finish by 20 minutes because we are running short of time. After Surya Kumar, I'll be talking about dengue and flu. And collectively, all three of us, Raghunandan, Surya Kumar, and myself, will take questions later. Surya Kumar, now the floor is yours.
Thank you, sir. Good evening to. Am I audible?
Yes, sir. You are audible. Your slides are visible.
Thank you, sir. So now the time is sharp 4:55, exactly 20 minutes. By 5:15, I will finish the show. So my topic is wise selection and interpretation of lab reports in infectious diseases. This is a very crucial step. And how to achieve this wise selection and interpretation, we call it as a term called diagnostic stewardship. Because nowadays it is very famous, the word called antimicrobial stewardship. Okay, now it is going to be famous and it is mandatory, the diagnostic stewardship. What is diagnostic stewardship? It has 5 pillars. Number 1, when to test, that is important. Number 2, what to test. Number 3, how to act on the results. And how to avoid harm to the patient. And very, very important, collaboration and communication. These are all the 5 major pillars of diagnostic stewardship. If we achieve the diagnostic stewardship, that is the base for antimicrobial stewardship. That is the foundation. If we want to achieve antimicrobial stewardship, first you should achieve the diagnostic stewardship. If you identify the correct pathogen, then only you can give the correct antibiogram. Okay. Next is when to test. Right time, right test, right patient is important. When the infection is suspected, that time you can test. There is no screening culture and all. When the symptoms are there, signs and symptoms, risk factors are there, then you can test. Before starting antimicrobial therapy, you identify the pathogen. To guide the appropriate treatment, we need to test. And severe persistent infections, we need to detect the complications. To confirm the diagnosis, you need to test. Mainly monitoring the therapy or response, whether the treatment is working or not, we need to test. And any outbreak or surveillance, we want to know the disease load, we need to test. Second pillar is what to test. Specimen, depending upon the clinical condition. We have blood, urine, respiratory, stool, swabs, serology, like many specimens are there. Depending upon the clinical condition and the anatomical site, we need to take appropriate specimen. Selection and collection plays a major role. The topic itself, wise selection, we need to select. For example, a patient is having pneumonia. Everybody says sputum. In case of COVID pneumonia, nasopharyngeal swab. In case of pneumocystis pneumonia, bronchoalveolar lavage, like that. So even though all causes pneumonia, sputum is not a only specimen. Depending upon the clinical condition, pathogen, suspected pathogen, we got different type of specimens. How to act on results, very, very important. Interpret in clinical context. We need to know about other tests, patient history, many factors, almost all factors we can analyze and come to conclude, not based on one test. And very important to a clinician and a microbiologist, we need to distinguish it's a colonization versus infection. Because same pathogen, some places it acts as a ambi, another it's onion. Some places it is colonizing, some places it's an infective agent. report critical values promptly. If anything going wrong, some critical value, suppose if I'm identifying bacillus anthracis in my lab, that should be, I'm pressing the panic button. And guided antimicrobial selection. Use culture and sensitivity. Based on the sensitivity you treat, and always go for neurospectrum antibiotics rather than broad spectrum. So that is called guided antimicrobial selection. I will give, as a laboratory person, 5 antibiotics are sensitive. Then I will say, give this first, give this second, like that. And de-escalate or optimize therapy. Suppose if you start broad spectrum antibiotic, after the culture results comes narrow spectrum, better you change, de-escalate. Or from intravenous to, you can go for oral therapy. And monitor response and adverse effect. So based on the results, you can go for all those things. Next is yes, this is the foundation of antimicrobial practice. Everybody knows what is antimicrobial stewardship. It is a patient safety is the first, because we are giving right drug, right dose, right duration. And it will reduce the resistance because we are properly using the antibiotics. And not only reducing the resistance, they preserve the antibiotic for future, because there is no options nowadays. And it improve the outcomes and reduce the stay in the hospital, reduce the cost of the patient. And antimicrobial stewardship is a teamwork, multidisciplinary, doctors, microbiologists, pharmacists, and infection control teams, many people involved. Very important, not only antimicrobial resistant, any program, if you want to implement, education and training is important. And without supervision, without monitoring, without audit, we cannot find the gap, we cannot improvement. There is no scope for improvement. So do audit, find the gap and improve. So these are all diagnostic stewardship. The diagnostic stewardship includes the wise selection and interpretation of results. Yes, these are the 3 important phases. One is pre-analytical phase. Any specimen collection is important. There is a nice proverb in Tamil, Mudal Konal, Mutrilum Konal, like that. If the specimen collection selection is going wrong, automatically the result will be wrong. We are doing with compromised specimen. If the specimen is compromised, you are forced to compromise in the results. Number 2, analytical laboratory. We need to give accurate result, because based on our result only, the treatment, everything is depend. The course of the patient's life and course of the treatment, everything is depend on the lab reports. It should be accurate, reliable. And very important, decoding the language of laboratory person. Laboratory person, we give one language result. Clinician perfectly, they need to decode. There should be perfect synchronization between clinician and laboratory people is mandated. Okay. Yes. I will give few case studies, very practical. Urine culture stewardship. Most overordered microbiological test in clinical medicine and most common source of unnecessary antibiotic exposure is urine culture. Another one is blood culture. Okay, I'll give one clue. 82-year-old nursing home resident with foul smelling urine, no fever, no dysuria, no flank pain, no altered mental status, urine culture, E. coli, 10 to the power 5 colony forming unit per ml, significant bacteria, susceptible only to broad spectrum antibiotic. Are you going to treat or not? Elderly person, E. coli is 10 to the power 5 significant bacteria, and it is susceptible to broad spectrum antibiotic. Are you going to treat or not? This is important. 90% of my kids, I asked my people also, everybody said, we're going to treat, sir. It is significant bacteria, sir. First thing, you should not test for this condition, because foul smelling is not a indication or signs and symptom of UTI. So asymptomatic bacteria may be a colonization state, not an active infection requiring treatment, except a few exceptions. If you treat this patient with broad spectrum antibiotic, you are inviting multi-drug resistant organism. So what is the error? Critical error, ordering urine culture based on smell, color, turbidity alone primary driver for use of unnecessary use of antibiotics, leads to multi-drug resistant organisms. So don't order the test because it is foul smelling or it is turbidity. Okay, like if the patient is having any flank pain or dysuria, okay, that kind of time you can go for urine culture. So treating asymptomatic bacteria does not prevent symptomatic UTI, but directly select multi-drug resistant organisms. So exception pregnancy, risk of ascending pyelonephritis. Number 2, if you want to do any invasive procedure which causes mucosal breach in anterior urethra and many other places, go for, you can treat. So significant bacteria you can treat in pregnant women and invasive procedure if the patient is asymptomatic. Otherwise, better don't treat. This is the take-home message. Do not order or treat based on smelly urine. ASB is common, elderly and catheterized patient. It is not an infection. Unnecessary treatment leads to resistance. And evidence-based decision protect patients today and preserve antibiotic for tomorrow. You got it? So pyuria is not a synonymous with UTI. Both are different. Absence of pyuria carries a high negative predictive value. Withhold antibiotic. Confident if there is no pyuria, can stop. Got it? Next is, so don't treat the culture, treat the patient. Always my teacher used to tell. Don't treat the culture, treat the patient. Culture report may be differ and patient shows differ. Be careful. Better judgment, better outcome. Case number 2, blood culture stewardship. Interpreting blood cultures accurately, especially distinguishing between bacteremia with contaminants, is one of the highest stakes decision in clinical microbiology. Still today, it is a gray area for many people. See the question. Post-operative patient with mild fever, 2 peripheral blood culture collected simultaneously, 2 set. 1 set shows coagulase negative staphylococcus. Another test no growth. What you're going to do? Because coagulase negative staphylococcus is a commensal. If both are growing commensal, then confidently I can say commensal. If one grows one, there is no growth. So interpretation, do not initiate any therapy unless patient has prosthetic device and any clinical sign of sepsis is present. Then you can go. Just mild fever, don't use. That not going to correlate. If the patient is having any prosthetic device, most common cause of prosthetic device infection, staph epidermidis, coagulase negative, or any clinical sign of sepsis, go for treatment. Otherwise, no. So right volume is important. Even if taking 1 volume extra blood, your diagnostic accuracy, sensitivity increased 3%. So give exactly 8 to 10 ml properly. Number of sets, 2 to 3 sets. That is very important. And timing before administration of antibiotic is the best. Even 1 single dose of antibiotic, the blood becomes sterilized. You won't get positive organism. And very important, never draw routinely from pre-existing vascular lines, source of infection, because high biofilm containing prosthetics, the biofilm act as a what is called a barrier to entry of antibiotics. It causes resistance. Next is differentiate contaminant from true bacteremia is very important. Correlate culture result with clinical picture, number of positive sets. Case number 3, decoding antibiogram. Understanding the language of susceptibility report. MIC value, what is MIC? What is SIR, susceptible, sensitive, intermediate, resistant? Okay, actually means in bedside. Clinician should know. For example, 82-year-old patient with community acquired pneumonia, sputum culture Klebsiella pneumoniae, ciprofloxacin gives MIC 1 microgram, E. coli 8 microgram. So which is best? Ciprofloxacin 1 microgram sensitive, ampicillin 8 microgram sensitive, ampicillin sulbactam. Okay, so we can easily say ciprofloxacin is more powerful because low 1 microgram it is killing. Ampicillin 8 microgram it is killing. Is it right? No, because you should not compare MIC value across different drug classes, because each drug is having different concentration, different mechanism of action, and it reach the site in different way. One drug will be very active in the in vitro, in vivo it may not reach the site. So never compare raw MIC numbers across classes. That is the take-home message. Select narrowest effective spectrum, reserve carbapenems, broad spectrum antibiotics, match the drug to infection site. For example, in that particular MIC, it will reach the site properly. In the site itself, in vivo also, we will get the same concentration. Then go for it. And de-escalate actively. Broader is not better. It leads to stewardship failure. So don't compare MIC classes. Consider the infection site and drug penetration. De-escalate narrowest effective therapy. Next is, for example, daptomycin. Are you going to give in pneumonia? Daptomycin. Are you going to give in pneumonia? You should not give, because daptomycin is a very good drug for MRSA. Best drug, MRSA. But what happened? It's highly active against MRSA in vitro. But it is neutralized by, inactivated by lung surfactants, pulmonary surfactants. So it's contraindicated in pneumonia. Vancomycin, CNS infection. Vancomycin is a very good drug for many pathogens, enterococci like that. But CNS infection, it cannot cross blood-brain barrier. Give linezolid. Nitrofurantoin for pyelonephritis. People say yes, because any UTI, give nitrofurantoin. It's the best drug for UTI. But its therapeutic concentration is seen in bladder, not in above the bladder. So it is never used for pyelonephritis, prostatitis, any systemic infection. Fluoroquinolones, excellent tissue penetration into lung. You can give. So before giving, don't see only MIC. Know the pharmacokinetics, pharmacodynamics, everything. Okay, parameters and pathogen-specific factor, patient-specific factor, disease-specific, everything. Pathogen, patient, and what is the disease condition, and the pharmacokinetics, pharmacodynamics of the drug, everything you consider and give the antibiotic therapy. Respiratory diagnosis, quality assessment and biomarker selection are two pillars of evidence-based respiratory infection management. I will tell. If the sputum specimen comes, we do gram stain. In the gram stain, it should be used for culture or not. I need to select. I need to have the guts to reject the specimen. If epithelial cells more than 10, reject. Polymorphonuclear pus cells more than 25, good specimen, take. We have the guts to how many people using the screening method in the laboratory. Whatever sputum comes, we put culture. We don't know it's a sputum or saliva. And the sputum collection is a very critical procedure. We need to educate the patient. Okay. And for example, procalcitonin CRP, which one you are going to choose as a vice person, right biomarker? Because procalcitonin specificity is 85%. And it is very early, 6 to 12 hours, it reaches peak. And de-escalation, excellently validated, 95%. So obviously we can go for procalcitonin. Even after healing also, CRP will present for a long time. We cannot totally depend on it. CRP has its own value, but if 2R comes, we can go for procalcitonin. And just treat only symptomatic patient, collect appropriate volume of blood, and correlate with the pharmacokinetics, pharmacodynamics, sputum culture, check the quality. Accept if the quality is present. It's a summary. Very important. Communicating with the lab. Lab is a consultancy, not a vending machine. So share the details with the laboratory person, ask why, what, how it happens, everything. Any atypical presentation, it should be informed to the laboratory. We will do according to that. We can add some test. We can do some extra thing. Suppose if we say in the urine, antibiotic already given, even few colonies will take it as significant bacteria. So the take-home message, order wisely, that is important. interpret in context, not only with results, de-escalate actively based on the result, collaborate with all people. Diagnostic stewardship is a multidisciplinary effort, not only laboratory, not only clinician, all people, including administrators. And very, very important, educate. Without education, you cannot implement any program. And stewardship is a shared responsibility. Protect our patient, preserve the power of antibiotics, improve the outcomes, and we'll build a healthier tomorrow. Now the time is exactly 5:14. 1 minute before I completed the presentation. Thank you.
Thank you, Surya. Excellent. You did a good job. The perfect timing. I really appreciate you. Yeah, you can
anyway,
exit.
I'm waiting. We will take the questions together, sir.
Yeah, we'll take all the 3 questions together.
Thank
you can exit and then I'll share my slides.
I'm exiting now. Thank you all.
Yeah. Have you exited?
Please, I exited, sir. I came out.
Sir, Neminathan sir, any issues sir? Are able to share the slides sir?
I'm not able to share my slides.
But you are a co-host, sir. There is a.
Yeah, I'm a co-host, but my slides are not.
Sir, are you in laptop only, no, sir?
Yes, sir. I'm in laptop. So what I'll do is I'll share my slides to you. Can you do it?
Yes, sir. Sure, sir. Or you can just go out and come in, sir. Sometimes it happens like that.
Okay.
Your slides are there, sir. CM in antibiotics do's and don'ts is a title, sir. It came.
That's not.
It's being shared, sir. I think you are now sharing now. I think because of some signal issues, it is taking some extra time.
Is it coming?
No, sir. It is processing, sir. It has started screen sharing, but we are yet to see it.
Maybe you started your screen, sir. Screen sharing is happened.
It's happening. Maybe because of a big volume of the slides, it may be taking some extra time, I guess. Looks like a network issue only.
So shall I share my slides to you, sir? Can you?
Yes, sir. Yes, sir. Please, sir. Sir, you can send the slides to me, sir. I will also try from here.
Yes, sir. I posted the slides in Amscon faculties.
Okay, sir. I'll try to get it. Sir, we have not received the slide yet in the group. Maybe.
Yes, sir. I will load it, sir. It's
Okay.
uploading.
Okay, sir. Okay, sir.
It came. Sir, shall I post, sir?
Yes, sir. Yes, sir. Please.
I will post. Yeah, I'm posting.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir. We can start.
You can start operating. Yeah. Yeah. Good evening, friends. At the outset, I'd like to thank once again AMS for giving an opportunity. Thanks to Namal, Dr. Sendil, Dr. Mohammed. Please go to the next slide. Friends, today we are going to discuss about 10 minutes each of dengue and flu. I'm sure that you will all agree with me. Sudden onset of high-grade fever, more than 102 or 103 with chills and rigors, with particularly headache, retroorbital headache, severe body pain, particularly joint pain, children not able to walk, with two rashes, one during the febrile period, evanescent rash, and a recovery rash. These type of presentation during a dengue season is, until proven otherwise, is a clinical dengue. So please remember, in dengue, the most important thing what you need to keep in mind is that complication can arise after 24 to 48 hours after the cessation of fever. That point you need to keep in the back of mind. Next slide. Vast majority, 75% of the dengue cases are asymptomatic in nature. They will come to you with URI, NRI, rhinitis, skin rash, joint pain. They will go to an orthopedician, they will go to a dermatologist, they will go to a general practitioner. Neither the doctor nor the patient knows that they got dengue. Their vast majority are primary dengue. They will go asymptomatically unnoticed. Only 25% of them are symptomatic, among which 99% are dengue fever, simple dengue fever, which doesn't require any management. Just outpatient management with paracetamol ORS is sufficient. Only less than 5% enter into severe dengue, of which if we diagnose correctly, the mortality can be brought down to 0. So if you don't recognize a danger sign, don't treat them, you will land up in problem. Next slide. So dengue basically is a 11-day illness. First 3 to 4 days is a febrile period in which nothing happens but for the fever. It's a period of viremia. Just give paracetamol, monitor the patient, educate them about danger signs. The second phase is called critical phase, which is from the 4th day to 7th day, 3 days, in which the patient goes in for complications like organ involvement, thrombocytopenia, bleeding. Sometimes some of the children go in for shock. Vast majority, 99% of the patients from febrile phase, they go to recovery phase. They do not require any treatment. They just go to recovery phase. So, vast majority do not require any treatment. Next slide. So, in febrile period, just the child is stable, vitals are normal. Just give them ORS and give paracetamol. Paracetamol preferably being epidotropic virus, give it a lower dose, 10 milligram per kg weight, not exceeding 60 milligram per kg per day. So, because many a times we do see in dengue patients, if you give excess paracetamol, you get paracetamol toxicity along with epidotoxicity of the dengue. You get two diseases. So, you have to be very, very careful. If you pick up warning signs and if you admit those children with warning signs, you can reduce the mortality from 25% to practically zero. So always give patient hearing to the mother's words. Mother is the best multipara monitor known to mankind. So whatever the mother says about the child, even a minute change in the pathophysiology, mother can recognize. Please give importance to the mother's words. Next slide. Next slide. So in outpatient setting, please remember, vast majority do not require any tests or antibiotic or steroids or IM injection. Never prescribe aspirin, ibuprofen, mefenamic acid. Do not treat them as outpatient because dengue is a dynamic disease. It requires fluids for 24 hours. Do not give BDIV fluids morning in your clinic and evening in your clinic. No commercial carbonated drinks like your Coca-Cola or Fanta, because they are already hyperosmolar in nature. They will cause cerebral edema. Do not admit patients unnecessarily just because NS1 is positive. It means there is a viremia inside dengue. As I told you, vast majority do not have the disease. So do not admit just based on the lab report alone. Next slide. So the timing of investigation is very, very important, as highlighted by Dr. Surya Kumar. Timing is very, very important. Do not do CBC for any febrile illness on day 1 because CBC will be invariably normal. Please do it after second day or third day. From day 0 to day 3, you can do NS1. Best do not do IgM and IgG. Never do by heart test because high false positivity, high negativity. Always do by ELISA method after 5th day. Next slide. So the most important thing that you need to see is transition from febrile phase to critical phase. If they develop danger signs such as abdominal pain or persistent vomiting or mucosal bleed or lethargy, restlessness, there is a tender hepatomegaly with signs of fluid accumulation with laboratory parameters suggestive of leukopenia, rapid decline in the platelet count, and rising hematocrit. You need to be careful. You need to admit these children. Please remember, dengue is not a platelet disease. It is, please, from today, forget platelets, focus patients. Next slide. So keep moving. Next slide. Yeah. Next. Yeah. Next. So if you look at this, go back to the previous slide. Yeah. If you look at this slide, these are 2009 guidelines about dengue. Patients with dengue with warning signs or without warning signs can suddenly develop severe dengue. So you have to be very, very careful. You have to educate them about warning signs. If they develop a severe dengue in the form of severe plasma leak or shock or fluid accumulation, severe bleeding or organ involvement, liver enzymes more than 1,000, CNS involvement, heart and lung involvement, you need to keep them in ICU, particularly children in PICU. Next slide. So, if they develop abdominal pain at the time of effervescence of fever, please put the child on the couch, put your hand on the right epigastric region, see for tender hepatomegaly. If that is so, that is the earliest sign of shock, that's the earliest sign of danger sign, child going from febrile stage to critical stage, keep those children inside. Do not think it as gastritis and give them antacid gel and send them home. Next slide. Please, you need to monitor certain important things, 5 important things. One is you have to monitor hematocrit, do not monitor the platelet. Always monitor the urine output. Minimal urine output should be more than 5.5 ml per kg per hour. Mean pulse pressure is the difference between systolic and diastolic. Always should be more than 20. If it is less than 20, you have to refer them to PICU. The heart rate, sudden tachycardia is a sign of impending bleeding, and increasing in respiratory rate sign means child is going for compartment syndrome. They will land up in pulmonary edema because of excessive fluids, particularly given during recovery phase. And please remember, many times you can have a normal systolic BP in a child with shock. Sometimes you can have a normal pulse oximetry. They are all red herrings. And the sensorium will also be normal in a child with shock. Please remember, in dengue, they can walk with shock. Next slide. So the most important thing is leukopenia, because this intense viremia happens inside the WBCs. So what the body does is, it does control it downregulates the production of WBC to cause leukopenia, so that the dengue viremia subsides. Next slide. So simple management is do a CBC, look at the hematocrit, start on 5 to 7 ml per kg of normal saline, which is ideal fluid. Never start dextrose containing fluid. It has to be given over a period of 1 hour. At the end of 1 hour, monitor the vital signs, urine output, see the capillary refill time, see the perfusion, look at the hematocrit. They are all improving. Reduce the fluids from 7 ml to 5 ml next 2 hours, from 5 ml to 3 ml next 2 hours. Within 24 hours, you can go to oral fluids, give ORS, and then monitor them. Usually the critical period lasts for 48 hours. If there is no improvement at the end of second bolus, you need to do a hematocrit and see there is a sudden drop more than 20%. You need to give packed RBCs 10 ml per kg. There's a sudden rise in hematocrit more than 20%. You need to give colloid 10 ml per kg. Next slide. These are the various permutations and combinations. If there is a NS1 alone is positive, probably the child has got dengue viremia. It does not mean that they've got a disease, does not require hospitalization unless they've got danger signs. In primary dengue, you can have a IgM positive even with low titers of IgG. That's primary dengue. Secondary dengue is a secondation, very, very important. When you have a high titers of IgG or with or without IgM positive, you can think of secondary dengue. Please remember, once IgG becomes positive, it will remain positive for lifelong, but in very low titers, that's a past infection. Once IgG is positive, look at the titers. If it is very low, you need not admit, you need not treat. That's a sign of past infection. Next slide. So Eurometer, Eurobag is very important tool. It's a 4-man CVP. You connect it and look at this. The child is 12 kilos. Child should have at least 6 ml every hour. Just monitoring this, you can make the child morbidity practically zero. Just connect this to the urine outflow tract. Next slide. So what you need to do is, in your outpatient, you have to see the color, capillary refill, temperature, pulse volume, and pulse rate. That's called CCTVR. I'm sure many of you have CCTVs in your hospital. Just remember the CCTVR. Next slide. So please remember, your fluids have got narrow therapeutic index. If you give beyond 72 hours, you land up in iatrogenic pulmonary edema. Next slide. So if the child is afebrile for more than 48 hours, with minimum 3 days from the recovery of shock, even if the low platelet count, if the child is clinically stable with a hematocrit that's normalizing, appetite that's reversing, disappearance of abdominal pain, you can discharge them. So platelet count is not an indication for admission, nor it's an indication for discharge. The child is clinically stable, you can discharge them. Next slide. So best co-prescription is ORS. Do not do CBC on day 1. Dengue should be clinically diagnosed. Do not rely upon lab alone. Counsel about day red flag signs in every viral fever during monsoon. Please keep this in back of the mind. They can walk with shock. Next slide. Simple tool in the management is to maintain urine output more than 0.5 ml per kg weight. Abdominal pain at the time of disappearance of fever is the earliest sign of plasma leakage. So avoid steroids, avoid IM injections, avoid NSAIDs, avoid antibiotic. Next slide. So IV fluids, as I already told you, you have to be used with caution and monitor the inpatients regularly because they can shift from a simple dengue to severe dengue in a matter of hours. From today, please forget platelets and focus on patients. Dengue is not a platelet disease. Next slide. Next, we'll go to flu. Next slide. Friends, flu is a syndrome that has got a high-grade fever, lethargy, loss of appetite, running nose, sore throat, dry hacking cough. Some of them do have diarrhea, nausea, vomiting. Next slide. So, group of viruses, ILI viruses, influenza, parainfluenza, human metapneumo, adeno, RSV, rhinovirus, and human COVID viruses can cause ILI, influenza-like illness. Next slide. So in influenza, you got type A is the commonest organism, commonest type that causes pandemics. So it infects both the humans and other species. Whereas type B is specific to humans, it causes sporadic disease. Vaccine contains type A and type B, and type C is ignored in the vaccine because it does not cause significant disease. Next slide. Basically, as a practitioner, if you look at the Lancet, children do have more of a fever and less of cough, and adults do have more of cough and less of fever. In elderly, it's more of rhinitis. So we have to be very careful when they present like this. Next slide. So as a practitioner, you have to categorize them based on the clinical symptoms. This is called influenza pyramid. 90% do have mild disease that forms a base. 9% do have moderate disease category B, and 1% have got severe disease category C. Next slide. This 90% do not require any test, do not require oseltamivir, home isolation because reproductive index is very high. When the child goes to school, they will infect the entire school. So you have to keep them at home for a period of 5 to 7 days. Never give steroids like in dengue because of the fear of Reye syndrome. No antibiotics, no steroids, no IM injection. Counsel about danger signs and monitor them at home. No tests, no medicine, just paracetamol. And if the child is less than 1 year of age, you can give them, ask them to do some steam inhalation. More than 1 year of age, for cough, you can give honey. More than 4 years of age, you can give them antihistamines and bronchodilators. Never give any cough syrup for less than 2 years of age. Next slide. If they got chronic disease of the heart, lung disease, or the liver, or the brain, or if the child is immunocompromised with like HIV or on steroids, or COPD or diabetic mellitus, any person who is having BMI more than 40, gross obesity, children below 2 years and adults more than 65 in pregnancy, these 10 are called comorbid diseases. Next slide. They got comorbid disease. Next, they automatically become category B, that is the 9% of the patients. In these conditions, based on a clinical judgment, you can give oseltamivir without doing lab tests. So 99% do not require lab tests. 9% require oseltamivir without doing tests. 90% do not require any tests. Even in category B, you can educate them about danger signs. You need not admit them. No need for routine antibiotics. Next slide. The same, if they got danger signs like tachycardia, tachypnea, hypoxemia, shock, hypotension, cyanosis, dehydration, CNS symptoms like drowsiness, dizziness, coma, or severe abdominal pain or seizures, these 10, they qualify to be category C. Next slide. In category C, which happens in only 1%, we need to do all 6 things at the same time. If they are having a small clinic, refer them to a center where there is PICU. In our hospital in PICU, we admit them, isolate them. On one hand, we do RT-PCR. On one hand, we give oseltamivir. We intimate the health authorities. This is only 1% of them. Very sick require RT-PCR. 99% do not require RT-PCR. 90% do not require oseltamivir. Please remember in the back of the mind. This one person requires antibiotics because they can develop ARDS, pulmonary pneumonia, or pulmonary sepsis. Only one person, third generation cephalosporin, particularly in our ICU. Next slide. So many times counts will be normal. There may be leukopenia. So counts do not help us. Next slide. The X-ray shows bilateral asymptomatic patchy pneumonitis mimicking ARDS. Next slide. You can have elevated LDH because of the cytopathic effect. If you don't treat a severe influenza, the mortality is very high. In dengue, if we don't treat a severe dengue, mortality is 25%. In influenza, mortality is 50%. So always you have to be very, very cautious. Next slide. So timing of oseltamivir is very, very important. As per New England Journal of Medicine, you need to make a diagnosis within 48 hours, start it as early as possible. Sometimes they come to you on third day or fourth day. Even if there is a delay beyond 48 hours, whatever the benefit the patient can receive, you can give oseltamivir. But ideally is before 48 hours. Next slide. So the dosage is 1 ml contains 12 milligram. In neonates, it's 12 milligram. Next slide. It increases with age. More than 1 year, it is as per kg. In adults and children more than 40 kilos, it is 75 milligram. For treatment, it is BD for 5 days. For chemoprophylaxis, same dose OD for 14 days. For neonates less than 14 days, do not give oseltamivir. There is no evidence. Next slide. Other drugs other than oseltamivir is zanamivir more than 7 years in single route. Perimivir, it is more than 2 years IV route for sick children. And baloxavir, even for more than 12 years, it's not available in India. It is an endonuclease inhibitor. It is a oral dose, single dose drug, particularly useful in giving for large gatherings where there's an outbreak. Next slide. So antibiotics are generally not required in any viral fever in an immunocompetent child. If there is a recrudescence or fever prolonged beyond the normal expected time, or there is a deterioration in the clinical condition, only in these 3 conditions you need to give antibiotics in viral fever. Generally, antibiotics are not required in viral fevers. That's an important message. Okay, next slide. You have to differentiate between common cold. Common cold is a mild illness in which fever is rare, mainly sneezing. Whereas in flu, sudden onset of high-grade fever with severe body pain with less of sneeze. So in common cold, even if you don't treat, it will last for a week. If you treat, it will last for 7 days. Do not treat a common cold. Next slide. So in influenza, you got rule of 2. Incubation period is 2 hours. Fever for 2 days. Cough for 2 weeks. In severe dengue, asthenia, body pain, malaise lasts for 2 months. That's called rule of 2. Next slide. Sometimes you can have pulmonary extrapulmonary complications. The pulmonary complications outnumber the extrapulmonary. You have severe pneumonias, both viral and bacterial, and sometimes you can have worsening of the COPD asthma. Many times these children, asthmatic children, come with status asthma with an infection of flu. Sometimes you do have children coming with para-influenza, coming with croup, and sinusitis is post-infection complication. And 25% of these children come with otitis media due to streptococcus, group A beta amyloid streptococcus following flu. In extrapulmonary, many times we do see children with comorbid disease coming to us with shock or multi-organ dysfunction. We do have renal failure, coagulopathy, myocarditis in the list, but they are less in number. Rarely you can have a encephalitis or transverse myelitis because this is a neurotropic virus. Please remember, during a flu season, 25% of your febrile seizures are due to flu. And many children come with myositis. They will have inability to walk because of the muscle involvement, particularly the anti-gravity muscles in the lower limbs. They'll be brought to you and put on the couch. If you do CPK, it will be lies in hundreds. So Rey syndrome is only iatrogenic because of your aspirin. Next slide. So you have, next slide. You got a subclad K that is spreading outside now. That is not present in the vaccine, but fortunately there's a cross protection against this. Now the present vaccine that is available is a trivalent vaccine Previously, last year, we had a tetravalent vaccine. Now the Yamagata strain has been removed. Because of the removal of one strain, the cost has come down by 1,000 rupees. Next slide. You got Southern Hemisphere, Northern Hemisphere vaccine based on the time of release of vaccine, which one comes in March, another comes in August. Next slide. You can use any one that is the latest. Live attenuated vaccine at present not available. It was available as Nasovac. It's given about 2 years, contraindicated in pregnancy because of its live attenuation. Next slide. The vaccine that we use in our practice is inactivated influenza vaccine. Given above 6 months of age, it's safe in pregnancy. The dose from 6 months to adults is same dose, 0.5 ml IM. When you are dealing with children below 8 years, you need to give 2 doses for the first time. Next slide. Since the virus has got minor antigenic drift every year, you need to give annual vaccination because the virus are new every year. Once in 20 years, 30 years, there is a major shift that's called antigenic shift that causes outbreaks like Russian flu, swine flu. Even in patients with egg you can give this vaccine. Flu vaccine can be concomitantly given along with other vaccines. Next slide. So basically, it's a vaccine, priority vaccine. I request all the doctors who are attending this vaccine to take a conference to take this vaccine. Next slide. So with this, let me conclude with my slides. And if you want my slides, you can note down my number 984221179. You can contact me for the slides. If there are any questions in the comment chat box, for all three of us, Dr. Raghunandan, Dr. Suryakumar, and myself, will be happy to answer. Suryakumar, if there are any questions in the chat box, you can please
Just
go
I'm
to
checking.
Dr.
I'm checking the
Sadiq.
chat box, sir.
You can see the chat box. Raghunandan, sir, any questions in the chat box?
Sir, question came for Raghunandan,
all three
sir.
of us will answer.
Sir, treatment of scrub typhus is azithromycin, doxycycline superior, or any only doxycycline is sufficient for good results? Am I audible? Scrub typhus, azithromycin with doxycycline is superior, or only doxycycline is superior? Raghunandan, sir? For me, one question. Can a sputum sample that has been refrigerated for 2 days after collection to be used for TrueNet MTB test? Yes, we can use, because even the bacteria, when you're keeping for cold storage, nothing will happen. And CBNAT is only, we are killing the bacteria and we are extracting the DNA and detecting DNA test. So no problem. Temperature will not affect CBNAT. Don't worry. Even after 2 days, if you keep in storage, you can use it. Next is any other question? After refrigerated 2 days, you can go for TrueNat as well as Gene Expert. Both you can do. Sputum. This is for Dr. Ebin Sam. Any other questions?
Dr. Ibrahim, any questions in the chat box? There is a question about there is a question about sputum collection for tuberculosis, sir.
So one question came, sir. It is typhoid sensitive to cotrimoxazole?
Yes, sir. Previously, a couple of years back, the typhoid was resistant to cotrimoxazole. Nowadays, we see lots of children in pediatric practice. Now, typhoid is becoming sensitive. So it's an orphan drug which was not used for many of us. Now, once again, we have started seeing sensitive to your the cotrimoxazole, bacterium and septron.
Yeah.
But unfortunately, 100% of them are resistant to quinolone. And
yes, I got a question, sir. In asymptomatic bacteria and pregnancy, can we start antibiotic in all trimester, or we can wait till the culture, sir? See, asymptomatic bacteria, we are finding with the help of culture only. After doing the culture only, if it is more than 10 to the power 5, we call it as asymptomatic bacteria. If you are found it in asymptomatic bacteria in pregnancy, treatment needed. Because already the immunocompromised in pregnancy status, 10 to the power 5, it is significant bacteria, even though it is asymptomatic, they need treatment.
Sir, another question is there.
One question in the chat box, sir.
Cardiac protection, flu vaccine and cardiac protection. I think for Neminathan, sir.
Yeah. Flu vaccine does have a primary aim of flu vaccine is to have a primary respiratory protection against viral pneumonia and secondary bacterial pneumonias. Secondary protection is there is lots of reports that say the incidence of ischemic heart disease is low, and secondary protection is cardiac protection. You can go ahead and give vaccine. You can take yourself.
And on typhoid
Sir, there is one question in the chat box to Neminathan, sir.
Yes, sir.
For a person who gets typhoid every year or every 2 years, can typhoid vaccine be beneficial?
Yes, sir. Please remember, typhoid is a disease which is caused by organisms. The inoculum is more. Sometimes we do see children who have taken typhoid vaccine, having gone to Mumbai and taken pani puri, and they come back with typhoid because your typhoid vaccine cannot protect them. The inoculum is very high. Usually, in the organism that is required 10 to the power 5, more than 5, if those much of organism go inside, they get typhoid. Whereas in the contrary, organisms like Shigella, even 5 organisms can cause severe Shigella. So if you really take a contaminated food, you will get typhoid. That's very, very important because it is more related to hygiene, water, sanitation, your food handling. That is very, very important more than the typhoid vaccine. So if the person gets a repeated typhoid, you have to educate him rather than giving more than typhoid vaccine because he is getting it because of his own hygiene problem. That's very, very important. But definitely he needs a typhoid vaccine. He needs education on typhoid vaccine.
Sir, another question. How common is the drug fever mimics infection? How to differentiate or how common it is?
Yeah. Many times we got around nearly 36 drugs can cause fever. Your outdated tetracycline, even your cephalosporin is given for a long time. Your multivitamins that contain niacinic acid that has drug fever. Many your anti-epileptics can cause drug fever. So there are nearly 36 drugs. If you look at the standard Nelson textbook of medicine, 36 drugs can cause drug fever. Most important thing is many times they admit the child in your hospital, they give 3rd generation cephalosporin for 5 days, 7 days, 10 days, and the fever keeps on coming. Many times there may not be any laboratory evidence or clinical evidence for infection. In those children, if you stop the drug, wait for 48 hours, fever automatically comes out. Your drug fever is confirmed by stopping the drug and seeing. Okay? So drug fever is very common. We do see, particularly in children, refer to our hospital for PUO. I'm sure Dr. Sadish must have had such experience. Sadish?
Yes, sir. Yes, sir. True, sir. We had such an experience with Tegretol. So that has produced drug fever. Then after withdrawing it, then the fever subsided.
Yeah, particularly you must remember the DRESS syndrome, drug-induced eosinophilia and systemic symptoms. It's a fatal drug fever. You have to be very, very careful, particularly when you are using anti-epileptics.
Another one more question.
I got a question, sir. I got a question.
Yes, sir. To Surya Kumar, sir.
Yeah, TrueNat. As I saw the question, sir. I have studied the question.
Yes, sir.
The TrueNat, if it grew in PHC, highly suspicious cases, it came as negative. But in district headquarters or the higher laboratory, the same TrueNat come to be positive. What is the reason? Very simple. If you are highly suspecting a case of tuberculosis, but it is negative in your TrueNat, okay, take the same sample, okay, do it in a higher laboratory. If it comes positive there, then there is some procedural mistake. So you need to find what is the mistake, whether it is a practice mistake or a person mistake. What is it? You can analyze. You can compare your report with a higher laboratory. Both are same. For yours negative, they are also negative. Then your test is good. Then any contradiction there in between, then there is some problem. You need to rule out the problem. Because it's you say it's a very highly suspicious case. It is negative in our laboratory. If the same sample positive in their laboratory, then there is one laboratory is wrong. If the concordant results, discordant results are there. Whenever discordant results are there, we need to do root cause analysis based on the root. There's a protocols there in CTD. So based on the root cause analysis, we'll find the gap and we'll fill the gap. That is the procedure. And if any discordant comes, that is the way we are going to rule out where is the mistake.
Thank you, sir. Another important question to Surya Kumar, sir.
Yeah.
So what is the time threshold from collection to submitting to the lab for each sample, like sputum, blood, CSF?
Yeah.
Urine.
Majority of the time as early as possible. For example, urine means within 2 hours. Sputum within 2 hours. Everything is as early as possible. If it reach the lab, it's very good. If it crossing above 3 to 4 hours, then we can go for storage, cold storage, or we can add some preservative, or we are using transport medium like that. For example, if in case of cholera, immediately we need to see under microscope, and suppose if it's got delayed, you can go for enrichment media. CSF, immediately it should be processed. If it got delayed, you keep it in room temperature. Don't go for refrigerator. So every specimen, there is a SOP. It should be reached in the lab as early as possible. If it beyond, suppose Friday evening, a microbiology lab will be closed by 4 o'clock, next day open by Monday. So those kind of time, what can we do? We have our own SOP, depending upon the laboratory. We can either store, you can add preservative, or we can put in colors or transport medium. Some way we can manage that time, but best is as early as possible. Thank you.
Thank you, sir.
Very good, Surya. I like to add, many times what happens in pediatrics, we ask them to collect the urine specimen, and we don't tell them about a midstream clean catch specimen. That's the most important. That gives a false positive result. So that the education before requesting for a urine culture is very, very important. As rightly told by Surya Kumar, urine has to be sent within an hour, number one. Suppose if you keep the urine for more than 1 hour and do urine simple microscopy, what will happen is when the time exceeds more than 1 hour or 2 hours or 3 hours, all the WBCs will lyse. So there will be urinary infection, but WBCs will be in the field will be 0. So you will miss an urine WBC parcels in the urine by keeping it for long time. Another important thing is, if you keep it for long time, these organisms like E. coli, Klebsiella, Proteus will multiply. So what is 10 to the power 1 will be 10 to the power 10 when you collect the sample after 3 hours or 4 hours. So less than 1 hour is a dictum. You have to do it. Suppose in case, as rightly told, if it is after 9 o'clock, lab has been closed, what you can do is you can keep the specimen urine in the fridge, in the door, not in the freezer, and then take it out immediately. After taking out, within 1 hour, you have to take it to the lab. That's important.
Thank you, sir.
Different methods are there, sir. You can add boric acid. Some different methods are there. Okay, that lab will tell. Okay, so next question.
Sir, some questions to Neminathan sir. Is there any test dose for vaccination? There are 3 questions. I'll tell all the 3 questions. Test dose for vaccination. And when can we give multiple vaccination at the same time? And also, after how many days or months we have to do the antibody titer after vaccination? All 3 questions.
Number 3. First, let me come to the last question first. Routinely, in an immunocompetent person, no need to do antibody titers following vaccination. Number 1. Number 2, you ask about the test dose of the vaccination. No vaccines require test dose because they do not produce anaphylaxis. If there is a previous history of anaphylaxis, you have to keep everything ready. Like that's a contraindication for vaccination. But anticipating anaphylaxis, you need to keep your clinic ASP ready to have anaphylaxis. As rightly told by Dr. Singaravelu sir, you must have injection adrenaline, you must have injection hydrocortisone, you must have oxygen, you must have ambu bag. Everything should be ready, particularly when you are doing a vaccination, because anaphylaxis in vaccination is extremely rare, but test dose is not required in any vaccination. Even your rabies immunoglobulin, WHO has removed the test dose because it has removed recently. And what was the third question? Multiple
vaccinations.
Please remember, you can give multiple vaccines on the same time. If you want to give 2 live vaccines, like you want to give a MMR vaccine and chickenpox vaccine, you can give on the same day. But you cannot give, at least there should be 4 weeks gap when you give live vaccines. On same day, you can give any number of live vaccine. You can give kill vaccine. You can give genetically modified vaccines. All 3 vaccines or 4 vaccines at the same time. We have hexavalent vaccine. It contains nearly around 6 infection disease put in a single vaccine. So you can give any number of vaccines at the same time. But when you're giving at the same site, you have to choose 1 inch apart. For children below 7 years, you have to give anterolateral mid-thigh, that is vastus lateralis, where there is no muscles or nerves. There is no nerves or blood vessels, only vastus lateralis muscle is there. For children more than 7 years, at the insertion of deltoid, never give any vaccine in the gluteal region. The message is you can give any number of vaccine. Body can sense more than thousands of antigens at the given time, and they can produce thousands of antibodies at a given time. So you can give any number of vaccine at the same time. But one simple rule is, if you are given a live vaccine for the next 4 weeks, do not repeat in between. After 2 days, they will tell, today I don't have money. Let me take MMR vaccine now. After 2 days, after my salary, shall I give chickenpox? No, when between 2 live vaccines, there should be 4 weeks gap. Otherwise, you can, on the same day, same time, you can give any number of vaccine. You can give anti-rabies vaccine with other vaccines. You can give flu vaccine with other vaccines. That's very, very important.
Got it. Got it, sir. Elaborate explanation. Thank you, sir. So there are a lot of questions on hepatitis B, because many of us are still seeing a lot of hike in hepatitis B infection nowadays. So we all took the vaccination during our MBBS entry. It is 016 and its validity for 5 years, and 01-12 validity for 8 years. Now for revaccination, do we have to do an antibody titer and give the vaccination, or what is the protocol, sir? Or we can directly give the vaccination?
Ideally, it is better to do antibody titer and give vaccination. But because since we are high-risk persons, healthcare personals, it is better to take a vaccine, booster dose.
So what is the dose or the frequency of the booster dose, or how often we have to give it?
So it's ideally when once the body senses an antigen, it produces a lot of memory cells, B cells, that will remain in our body for lifelong. So even if some virus enters the body, for example, if you're taken a chickenpox vaccine, after 50 years or after 100 years, if chickenpox virus enters, though the titer will be low, it will produce anti-chickenpox antibodies anamnestically, rapidly. So you will get protected against that. So titers may not be significant at a given point of time. When antigen enters, immediately because of the presence of memory cells, we need not do antibody titer. It will immediately produce antibodies because of the memory cells.
So how often we need to repeat the booster dose, sir? Like every 5 years once or 3 years once? Sir, Neminathan sir, how often we have to repeat the booster dose for hepatitis B vaccination?
Yes, sir.
How often we have to repeat the booster dose for hepatitis B vaccination, sir?
Yeah.
Every 5 years or 3 years?
No need for booster vaccination. No need. It will be giving lifelong protection.
Okay, sir.
Almost 20 years protection it gives, sir.
So many of these vaccines, when they cross this line of more than 10 years, previously when hepatitis B was there, when we came into market, we said give booster dose after 1 year. Then we were looking at the antibody titers. Then after 5 years, we said give booster dose at 5 years. Then after 10 years trial, the antibody titers were remaining high. So then after that, we said that it will give lifelong protection, no need for revaccination. So now that hepatitis B is a time-tested vaccine. So if you have taken a full course, no need to give booster dose.
Is there any other question from the audience? You can just unmute yourself and ask, sir. Or you can raise your hand and then unmute and then ask. We have already crossed the time of 6. It is 6:03 now.
Sir, can we give MMR 4 days back? Shall we give OPV during pulse polio campaign? Yes, you can give. You can give MMR vaccine and oral polio vaccine together because the route of administration is different and you can give.
Please remember regarding the pulse polio campaign, even if the child has taken the normal oral polio drops and IPV injection, every child less than 5 years of age in the entire country should take the vaccine. Please remember, don't tell that my child has taken my vaccine schedule. Please remember always Whenever you have to educate them, you have to tell them, suppose they are living in a colony, வீட்டில் எல்லா வீட்டையும் வந்து பூட்டு போட்டு லாக் பண்ணியிருப்பாங்க. பட் ஸ்டில் அந்த காலனியில் வந்து ஒரு செக்யூரிட்டின்னு இருப்பாங்க, கூர்கான்னு இருப்பாங்க. சப்போஸ் இப்போ நம்ம ஒரு ஊர்ல இருக்கோம் அப்படின்னா நம்ம வீட்டில் எல்லாரும் இண்டிவிஜுவலா லாக் பண்ணியிருப்போம். பட் ஸ்டில் போலீஸ்னு ஒருத்தங்க இருப்பாங்க, பேட்ரோல்னு வருவாங்க, எல்லாம் பார்த்துட்டு இருப்பாங்க. ஸோ அதுக்காக நம்ம வீடை பூட்டி இருக்கோங்கிறதுக்காக செக்யூரிட்டியோ இல்ல கூர்காவோ இல்ல போலீஸோ இல்லாம இருக்க முடியாது. ஸோ யுவர் இண்டிவிஜுவல் வேக்சினேஷன் இஸ் லைக் லாக்கிங் யுவர் ஹவுஸ் and your pulse polio is for the nation, for the whole country, for that has to be like, it is like our police or military. So everybody should take the vaccine. That's an important message, irrespective of your child's immunization, individual immunization. Even if they have taken a polio drops yesterday for the child, and if the National Pulse Polio Day comes one day later, they have to take it. That's very, very important.
Sir, another question which is oft repeated. If someone who is not sure of the vaccines they took in the childhood, what are all the vaccines that the adult should be taking now?
So if they are not sure, that means totally they are unprotected. Vaccines like polio, your rotavirus, they need not be given. That's only childhood disease. Other vaccines they have to take. They are not sure. Like diphtheria, pertussis, tetanus, hepatitis B, hepatitis A, typhoid, influenza, pneumococcal vaccine, everything they have taken. If they are more than 65 years, they have to take even pneumococcal vaccine.
Thank you, sir. Is there any other doubt from the audience? You can just post again because we have already passed 6. There is another last question. We'll take it, sir. Previous chickenpox timing of shingles vaccine. There is a previous history of chickenpox. What will be the time of shingles vaccine?
Tell me, can you repeat the question?
Sir, there is a previous history of chickenpox. What will be the timing of shingles vaccine now, when we have to give the next vaccination for shingles?
Anytime, sir. There is no
Anytime.
proper time limit. If a
Okay.
person already had chickenpox in the age of 2 or 3 or 5, it may be latent in the body. It may be reactivated at any time. So you can give the zoster vaccine at any time. Okay.
Okay, sir. So another question.
Because chickenpox is a live attenuated vaccine, zoster vaccine is the recombinant vaccine. So we can give.
Okay, sir. What about HPV vaccination for adult male?
The protocol is there, sir. Sir told actually.
Yes, sir. And I think we have come to the end. Is any other points, sir? Moderators, if they are there, they can. Sir, is there? I think we had a very great discussion, elaborate discussions on various things. Shall we go to the vote of thanks, sir? Surya Kumar, sir?
Yes, sir. Thank you, sir. Thank you all. Patient listening. Thank you, sir.
So on behalf of IMA TNSB AMS, I am Dr. Mohammed Ibrahim, Joint Secretary of the IMA AMS TNSB team. I thank all the speakers, Dr. J. Shyamala, Dr. Suresh Kumar sir, Dr. Surya Kumar sir, Dr. Neminathan sir, and Dr. Raghunandan sir, and above all, the moderators, Dr. Singaroilu sir and Dr. Satish sir, for their elaborate explanation and wonderful sharing of their knowledge on infectious diseases on both adult and pediatrics, and also highlighting the importance of vaccinations and the recent trends, including the monsoon infections. And on behalf of IMA TNSB, I thank our TNSB state team, our President sir, Secretary sir, and Finance Secretary sir, Dr. Sridhar, Dr. Thiravi Mohan sir, and Dr. Solomon Jaya, and also the President-elect, Dr. NRTR sir, for joining us, and also the past President, Dr. Singatuan sir, for joining us. And I thank the entire team of IMA TNSB and also the IMA AMS national team for their encouragement and support throughout the thing. This is just our first day of the 5 days marathon Amscon. The last day, final day, will be a hybrid one where the final thing will be happening in the Pollachi, our secretary's place. And above all, the most important thing was the participation from the audience. It was completely 1,000, and we have to create a waiting hall to allow the speakers to get in. So in between the meeting, we created a waiting hall so that the speakers can get in, because the hall was entirely full. And I thank all the, even at the end now, it is almost 800 plus. So I have never seen such a Zoom meeting on these topics. So I thank the audiences are spellbound because of the speakers. So I thank all the speakers, the audiences, the organizers on behalf of IMA, AMS, TNSB, and we'll be meeting again tomorrow for another wonderful day. Thank you all. Thank you for the participation. Thank you. Good evening.